Hello everyone. The Path Hemat session followed by Path Systemic is about to commence. I have the privilege of welcoming our awesome faculty, Dr. Sanjeev Chitrakar, a wonderful educator who has dedicated his life to imparting valuable knowledge to young doctors seeking academic excellence. Dr. Sanjeev Chitrakar is an MBBS graduate from Mysore Medical College, MD Pathology from All India Institute of Medical Sciences, New Delhi. He's got a higher further degree in oncopathology and has a vast experience of around 16 years. Let's welcome Dr. Sanjeev Chitrakar. Over to you, sir.
Hi guys, all of you. Yeah, I know you have had a lot of patience and you waited for a little bit more time than expected. Don't worry, I will make sure. Sorry for the trouble, all of you. Yeah, so I'll make sure you will be well compensated with 25 marks in your NEET PG that you're going to write. Okay, so let us start. I'm Dr. Sanjeev Chitrakar, all of you know. So we will start with two topics now. I'll be taking hematology and systemic pathology. So what I want from you guys, yes, I don't want to open your books. I will tell you when to open. Okay, and all that I want is just a minute. Yes. So all that I want is all of you have an open mind, keep listening, try answering, keep answering in the chat box. Okay. Yes. So let us start. There is an echo. So all that I want is no, there is now no. No, there is no voice echo. Initially I had yes. Good afternoon, everyone. Good afternoon. Right? Okay, let us start with our first slide. I am discussing approach to anemias. How do we approach anemias? So there are flowcharts. You will be able to see this. And yes, nothing to write. It is already written to you guys. I want you to answer in the chat box. Let's start with approach to anemia. What is the first investigation you will look in anemia? In anemia, always remember, of course, anemia is hemoglobin reduction. We know that. We look for red tick count. That is the most important investigation. Most important investigation is your red tick count. So can anybody tell me what will you look for in red tick count, please? Yeah, hemoglobin is low in anemia. Yes, correct. So we are looking for red tick count, reticulocyte count less than 3 or more than 3. That is what we are looking, less than 3 or more than 3. Less than 3 we call it hypoproliferative anemia, isn't it? Hypoproliferative. What is hypoproliferative anemia means? Hypoproliferative is where bone marrow is proliferating less. That is hypoproliferative. More than 3 will be hyperproliferative anemias. More than 3 will be hyperproliferative. No, audio is also fine. I am checking myself on the phone. Audio is fine. Those who are there who don't have good audio, please re-log in. Go back and come join again. Okay, hypo and hyperproliferative. Hypoproliferative, what do I, next investigation I look? Next investigation I will be looking is your MCV, mean corpuscular volume. Mean corpuscular volume. Can anybody tell me now? 3 things. I will look at 3 things here. MCV. MCV could be less than 80. Yes, it could be less than 80. It could be 80 to 102 or more than 102. So what is it? Less than 80. What will that be? Yes, less than 80 will be microcytic anemia, isn't it? Microcytic. Very good. Microcytic anemia. Next is your 80 to 102. This will be your what? Macrocytic anemia. This will be macrocytic anemia. 80 to 102. And more than 80 to 102, normocytic anemia. Very sorry. And more than 102 will be macrocytic anemia. Yeah. So micro, macro and normocytic. Now let us further look at microcytic. What do I do? Most common. What are the DDs for microcytic anemia? Yes, in the chat box I want to look. What is the mnemonic that we had discussed? Sita is your mnemonic, isn't it? Sita will be sideroblastic, iron deficiency, thalassemia and anemia of chronic disease. Sita, isn't it? Yes. So what do I do? In India, most common cause is iron deficiency anemia. That is why we will give challenge oral iron for 1 week. Give challenge oral iron for 1 week. What do you mean by challenge oral iron for 1 week? Basically, we are going to challenge the disease here. That is what we are going to do. So we give oral iron for 1 week and check if the patient is responding or not responding to this. After 1 week, what is the, yes, how do I check whether there is response or no response? How do I check it? Yes, anybody, how do I check the response? How do I check the response? Retic count. Very good. Check for retic count. So this is in page number 1, first page we are still talking. So retic count, page of hematology, sorry, hematology section, first page. Yes, retic count. Retic count increases or does not increase. See, basically whatever was the baseline retic count in the patient, whether the retic count is increasing or it is not increasing, that is what I will look for. If retic count increases, what do you think of? Tell me, if retic count increases, what do you think of? Yes, retic count increases, then you think it is a iron deficiency anemia. That is your diagnosis. And if it is iron deficiency anemia, what is your treatment? Can anybody tell me what will be the treatment for iron deficiency anemia? Oral iron should be given. We know that oral iron, what is the dose of oral iron? Yes, and how long oral iron should be given? Continue oral iron, because you already have started oral iron here. Continue oral iron for 6 to 12 months minimum. Why 6 to 12 months? Although hemoglobin gets normalized by 3 months, you still have to continue oral iron for long. The reason being, stores have to be replenished there, isn't it? Yes, continue oral iron for next 6 to 12 months. What is the dose of oral iron? Yes, the dose of oral iron is up to 200 milligrams per day of elemental iron in divided doses. 200 milligram of elemental iron in divided doses. Yes, correct. So iron stores, to stores become normal, it will take minimum 6 months is what is the time taken. That is why we have to continue oral iron for such long. Now, what if, okay, somebody is writing 60, yes, 60 is your elemental iron available in the government supplies, most of the supplies. So we give TID or BD also can be up to 200 milligram is what we give. Now, what if it does not increase? What if there is no increase in retic count after giving challenge oral iron? Then what do I do? Do iron profile. That is what we have to be doing now. Iron profile of the patient. Do iron profile. Iron profile includes 4 important tests. Can anybody tell me which are the 4 important tests of iron profile? Serum ferritin, total serum iron, TIBC, and a transferrin saturation. Correct? So we do iron profile. Yes, we need to remember values of iron profile. Okay, let me tell you iron profile first thing. In iron profile, easy to remember. All, okay, now open your books. There is one mistake that I have done in the printing version. So please change this. Due to copy paste error, there was a problem. So all decreased except TIBC. In your book, it has been printed as all increased except TIBC. Just change it. Decreased. The word is decreased here. Okay. All decreased except TIBC. All decreased except TIBC is one situation. Second situation, all decreased except serum ferritin. That is the second. The third one will be opposite of the first one. That will be all increased except TIBC. All increased except TIBC. And fifth one will be, the fourth one will be all normal. So please change this in your, please make this addition in your or correction in your books. Please make this. Now, can anybody tell me what is the first scenario? All decreased except TIBC. What are all those things that I am talking about? Serum iron, serum ferritin, and saturation is decreased. TIBC is the one which is increased here. What are you thinking? You are suspecting a iron deficiency. No, audio is all fine. Everything is fine. So you are suspecting a iron deficiency. Yes. What are you thinking? Yeah. So iron deficiency. What are the other confirmative investigation that I can be doing? The other confirmative investigation could be, yes, increase in serum transferrin receptor 1 levels. Mark this star mark here only and you add it in your notes now. This is the most specific test for IDA. Most specific test for IDA is what? Increase in serum TFR. And also increase in porphyrins. Porphyrins will also be increased in iron deficiency. Porphyrins will be increased in iron deficiency. Now, so if I have this, what do I do? What will be my treatment? Of course, this is an iron deficiency, but this is a malabsorption. That is the cause of iron deficiency here. This is a malabsorption which is causing iron deficiency. Why do I call this as malabsorption causing iron deficiency here? Because patient did not respond to oral iron. Look at this, patient did not respond to the oral iron. That's why I'm calling them as malabsorption. So if it is a malabsorption, what will be your treatment? Then tell me. If it is malabsorption, the treatment will be iron injection. Injectable iron should be given, isn't it? Yes, injectable iron. Yes, mnemonic is SITA, S-I-T-A. S is sideroblastic, I is iron deficiency, T is thalassemia minor, and A is anemia of chronic disease. That is a mnemonic for microcytic anemias. Mnemonic for microcytic anemias. Next. So all decreased except serum ferritin. The second scenario, what are you suspecting here? You are suspecting anemia of chronic disease. For anemia of chronic disease, you will have other concomitant history or investigation suggesting a chronic disease. So what are the other investigation or history suggesting a chronic disease? Like CRP will be increased, then TLC can be increased, or ESR can be increased. Yes, so this will be your anemia of chronic disease. What will be the treatment for anemia of chronic disease? Anybody? Treatment for anemia of chronic disease will be, yes, treat the disease or treat the cause. Whatever is the cause, that should be treated. Treatment of anemia of chronic disease. Next, the third one, what is it? All increased except TIBC. Can you tell me what is this? All increased except TIBC. What is this? Exactly opposite of iron deficiency anemia. You are suspecting a sideroblastic anemia here. So you check for bone marrow aspirate, and the bone marrow aspirate is likely to show sideroblast. What are sideroblasts? Iron containing precursors that are sideroblast, and diagnosis sideroblastic anemia. Diagnosis is a sideroblastic anemia. What is the treatment for sideroblastic anemia? Anybody? What is the treatment for sideroblastic anemia? Treatment for sideroblastic anemia is, yes, treatment of sideroblastic anemia. What is the treatment? Vitamin B6 supplements to be given. Vitamin B6 or pyridoxine supplements can be given. Okay. Sideroblastic anemia, sorry, it is going behind here. Yeah. So give vitamin B6 supplements, that is one. Pyridoxine, and also treat the cause. There can be treat the cause also, that will be there. What are the other causes of sideroblastic anemia? Can you tell me what are the other causes of sideroblastic anemia? Other causes of sideroblastic anemia? Heavy metal poisoning. One important cause is heavy metal poisoning, and which is commonly lead poisoning. So you have to treat that. All normal. What are you suspecting? If all normal in iron profile, suspect thalassemia minor. So that is why we have to do HPLC. What is HPLC? HPLC is, yes, high performance liquid chromatography. HPLC, high performance liquid chromatography. On this, we check for hemoglobin A2 levels. A2 levels should be between 3.5 to 9%. That is diagnostic of Thal minor. Yes, diagnostic of Thal minor. What do I do for Thal minor? Genetic counseling. So we have to do genetic counseling. Management of Thal minor will be genetic counseling, right? So these were your microcytic. For microcytic approach, let me just tell you, first retic count, then what? MCV, then what? Iron profile, right? This is what we have done. Now next is the other side was normocytic. What are normocytic anemias? Normocytic will have MCV between 80 to 102. What do I do if it is a normocytic? Normocytic can further be divided into two. Retic count between 1 to 3% and there is no pancytopenia in the patient, or retic count less than 1% and pancytopenia. Can you tell me what is this condition? Retic count less than 1 and pancytopenia is there. What is your diagnosis here? What are you thinking of? Yes, you are thinking of a aplastic anemia here, isn't it? Yes. On the other side, this is not aplastic, because in aplastic retic count will be less than 1%. So this will be anemia of hemodilution. What is anemia of hemodilution here? Anemia of hemodilution will be whenever there is an anemia happening or whenever there is an acute blood loss. It is also called anemia of acute blood loss as well. When acute blood loss happens, you lose volume of the blood and also you lose one RBCs, and your kidney immediately senses there is a loss of volume and kidney starts retaining water due to RAS activation. Once the kidney retains water, you end up having what? The blood volume comes back to normal, so your RBCs get diluted. That's why it is called anemia of hemodilution. Anywhere else anemia of hemodilution happens? Yes, correct. It will happen even in pregnancy as well. Even in pregnancy, because the volume expansion of plasma is more in pregnancy. Another condition, normocytic anemia without pancytopenia, anemia of CRF. What is anemia of CRF? Anemia of chronic renal failure. Anemia of chronic renal failure. Yes, anemia of chronic renal failure. So patients with CRF have reduced erythropoietin production. Erythropoietin is less, stimulus to the bone marrow will be less. Whereas red tick count less than 1% and there is a pancytopenia, the diagnosis remains your aplastic anemia. For that, we can do bone marrow aspirate. Bone marrow aspirate will show dry tap, we know that. And bone marrow biopsy will be showing only fat. There is the only fat seen on bone marrow biopsy in case of your, yes, in case of aplastic. So this will be aplastic anemia, isn't it? Yes. So these are your normocytic anemias. Two important normocytic anemia, anemia of hemodilution and anemia of CRF. That is one condition. Another is aplastic anemia, which will be normocytic. Yes, normocytic. Anemia of chronic disease, chronic inflammation will lead to anemia. Because of chronic inflammation leads to increase in positive acute phase reactant, which will include hepcidin, which will destroy the ferroportin in the gut, and thus absorption of iron will not happen. That is anemia of chronic disease. The morphology of microcytic will be there, initially normocytic, but important distinction from IDA will be by iron profile. In anemia of chronic disease, there will be what? All decreased except serum ferritin. In anemia iron deficiency, it is all decreased except TIBC. Okay, right? Understanding all of you? Yes. Next is, okay, this is one flow chart where you'll end up revising the whole of anemia basically. That is what I am doing here. Okay, or two flow charts are there, 2 pages in your printout. Okay, now next is macrocytic. What is macrocytic? We said MCV more than 102, isn't it? More than 102 MCV, check for morphology. On morphology, are you finding hypersegmented neutrophil? Check for hypersegmented neutrophil. If you are finding hypersegmented neutrophil on morphology, tell me now, two possibilities. Hypersegmented neutrophils are present or absent. What do you mean by, if hypersegmented neutrophils are present, what are you thinking? If they are absent, what are you thinking? Now tell me. Yes, I will answer first with absent. So if there are no hypersegmented neutrophil, this is not a megaloblastic. If you remember, macrocytic can be divided into megaloblastic and non-megaloblastic causes. Megaloblastic means in the bone marrow, there will be large erythroid precursors in the bone marrow. So if your hypersegmented neutrophils are absent, this is a non-megaloblastic cause of macrocytic anemia. Cause could be thyroid diseases, liver disease. Very rarely, you can add one more, I have not added here, very rarely even aplastic anemia as well. Aplastic anemia also can lead to macrocytosis. Usually aplastic anemia will be what? Normocytic, but can also lead to what? Macrocytic anemia. You can just add word here, aplastic as well. It will be a non-megaloblastic cause of macrocytic anemia. Non-megaloblastic cause of, yeah. So alcoholic ultimately will cause liver disease, and that will also lead to same. Okay, alcoholic lead to liver disease. That will, thyroid disease mostly are autoimmune diseases. Okay. Yes, even autoimmune diseases can cause this, especially thyroid diseases. Now, next is hypersegmented neutrophil. If they are present, then what? If hypersegmented neutrophils are present like shown here, it could be because this is your megaloblastic anemia. Megaloblastic could be two causes. Anybody remembers which are the two causes of megaloblastic? B12 deficiency and a folate deficiency. So now what will be the clinical giveaway in the question? In the question, keywords that will be given to distinguish iron from folate deficiency. Let me give you some keywords. Tell me now. The keywords that I am giving, tell me B12 or a folate deficiency. Okay. Yes. Keywords, gastrectomy. Tell me now. Gastrectomy patient having hypersegmented neutrophil. What are you thinking? Gastrectomy is a keyword given to you. Yes. Tell me what are you thinking? Gastrectomy. Or patient is having a neuropathy also. Burning feet, burning hands are there. Or patient is having increased excretion of methyl melanoic acid in urine. That has been given to you. Yes, all these are suggestive of what? And the patient is a pure vegetarian by diet. These history, if they are given, what are you thinking of? Neuropathy or pure vegetarian by diet or gastrectomy? Yes, very good. We suspect what? B12 deficiency. Correct. So, neurological manifestation, look at this here. Neurological manifestations, or if there is any ileal diseases like Crohn's disease of the ileum, then gastrectomy history given. Vegetarian diet given, autoimmune association, especially pernicious. Autoimmune condition will cause what? Pernicious anemia, right? Yeah, that, or even achlorhydria will be given to you, right? Then hyperpigmented knuckles, clinically, that will be seen in B12 deficiency anemia. hyperpigmented knuckles, increased methylmalonic acid, and homocystinemia. All these are suggestive of B12 deficiency, correct? On the other hand, okay, one more thing here only I want to mention. After gastrectomy, remember, stomach is required for both absorption of iron as well as vitamin B12. Vitamin B12 because it is required for secretion of intrinsic factor which is secreted by stomach, and for iron absorption it is required because conversion of ferric to ferrous in iron absorption is done by acid which is secreted by stomach, by the way. So when gastrectomy happens, you can develop both iron deficiency and you can develop what? B12 as well. But very important to understand, the iron stores in your body last very less. That is why the first deficiency that you're going to have after a gastrectomy will be iron deficiency. Subsequently, which will happen within few months, whereas B12 deficiency takes at least 1 to 2 years to have a deficiency anemia after gastrectomy. So if they give you a question, this came in inicet last year. Let me give you that question now. What was the question? Patient underwent gastrectomy. 3 months later, patient developed anemia. Which of the following is the most likely deficiency? I am looking at the chat box. Please tell me now. Which of the following is the most likely deficiency? Iron or vitamin B12 or folic acid also was given in the option. Tell me now what is the answer. Iron, folic acid, B12. What is the answer here? Yes. What is the answer? Iron. Yes, iron, B12 or folic acid. Now look, what is the keyword here? Is gastrectomy keyword? No sir, not a keyword. Why? Because both iron and B12 can be because of what? Gastrectomy. Anemia is also not the keyword because both of them cause anemia. Keyword was the age, time of onset of disease after gastrectomy. It was given only 3 months. I told you B12. So both B12 and iron will be deficient if you are not eating what? If you have done a gastrectomy. But deficiency sets in. First will be what? Iron. B12 takes 1 to 2 years to set in. That is the reason why in this case answer will be what? Iron deficiency, not a B12. Yes, the keyword there was what? 3 months was the keyword there. Okay. Yes, very good. Then next, another history I am giving you. Let us see. Not eating vegetables. Patient is not eating vegetables or fruits. Fresh fruits and vegetables are not eaten by the patient. Alcoholic patient or a patient with malignancy or inflammation or pregnancy or celiac and tropical sprue. So remember, celiac and tropical sprue, both of them are enteropathies involving the upper intestine. Anybody remembers? Tell me now 3. Absorption of iron, folic acid and B12. Tell me where will they get absorbed? Iron gets absorbed from 3 things. Please in the chat box. Absorption of iron, B12 and folic acid. Where is it getting absorbed from? Iron is from stomach. Folic acid is from jejunum, correct? And B12 is from ileum. So your celiac, look at this. The celiac and the tropical sprue are the enteropathies which involve the upper part of the intestine. That is why if they are there can be deficiency. Tell me now, celiac will have a deficiency of what? Iron and folic acid or iron and B12? What will be the answer? Tell me, iron and folic acid or iron and B12? What will be the answer? Yes sir, what will be the answer? Celiac will have a deficiency of iron and folic acid. Now, yes, I am giving you an expected question in inicet and neet PG, both of them. Let me give you a question. A patient underwent gastrectomy and he has developed a dimorphic anemia. Can you tell me what are the deficiency? What is a dimorphic anemia, by the way? Dimorphic means 2 morphologies, both microcytes as well as what? Macrocytes are there. That is a dimorphic anemia. Tell me now, what will be the answer? After gastrectomy, dimorphic anemia, what deficiency I am asking you? Yes, what is the answer? Iron and folic acid, true or false? After a gastrectomy, iron and folic acid, true or false? False. It is what? Iron and vitamin B12, not folic acid, because of gastrectomy. Now let me give you a question. Patient with celiac is manifesting with a dimorphic anemia. What are you thinking of? Tell me now. Iron and B12 or iron and folic acid? Tell me. What are you thinking? Second one. Iron and B12 or iron and folic acid? In a patient with a celiac or a tropical sprue. Celiac sprue patient having dimorphic anemia. What are you thinking? Yes, very good, very good, very good. I can see most of you are answering it right. Very good. Tropical sprue or celiac sprue, iron and folate deficiency will be there. Okay, yes, correct. Next, Only one more thing in folate, you can get increase in fig glue excretion. Okay. Yeah, this question in fact came in previous year. Let me ask you a question. This question, let me see how many of you can answer. Patient presents with patient 36-year female, software engineer. Since onset of lockdown in COVID, this question came by the way, and she is not able to cook her own food and she is eating junk food. She doesn't eat fresh fruits and vegetable. Her hemogram shows hemoglobin 9 and MCV was 110. Tell me now, what is the answer? What is the answer? What is your definition? What is your diagnosis? Yes, what is the diagnosis? What is the diagnosis in this? Keyword. What is the keyword here? Okay, the first one we understood, B12. Second one is what? Folic acid deficiency. Yeah, in this it is the folate deficiency because she was not eating fresh fruits and vegetable. See, very important. Let me just summarize this whole table. What should you look for in anemia? Whenever there is anemia, hemoglobin will be low. We need not break our head with hemoglobin. It doesn't tell me the cause. But I look for reticount. That's the first investigation I look for. Second, I look for MCV. These are the two giveaways for me. If examiner has not given you MCV, let me see how many of you can answer this question now. Take your time. Take your 1 minute or half a minute time. I'll give you half a minute time. Patient's hemoglobin is 9 grams per deciliter. Hematocrit or PCV is 36%. And RBC is 3 million. Which of the following is the most likely deficiency? Option iron. Second option vitamin B12. Third option folic acid. Fourth option any of the above. Yes, I will repeat. Okay. Question I'll repeat again. What is that? Okay. Patient's hemoglobin is 9 grams per deciliter. PCV is 36 and RBC count 3 million. RBC count 3 million. Retic count 1.5. Retic count 1.5. Yes, sir. What are you thinking of? How did you arrive at answer? Okay. Well, yes, many of you are answering it iron. Some of you are answering iron. How did you get iron? Somebody is answering megaloblastic here. Okay. Somebody is answering megaloblastic here. Yes. Okay, approach. Look at this. In this, the examiner is smart here, trying to not give you something you wanted. I have given you reticount. Reticount is what? 1.5. That is okay. Less than 3, understandable. But you are looking for next what? MCV, isn't it? Yes, sir. You are looking for MCV, but examiner has not given you MCV. So now next thing you have to, what is examiner expecting? The key point in this was examiner is expecting you to calculate the MCV. Examiner is expecting you to calculate the MCV. Anybody remembers formula for MCV here? Please tell me the formula for MCV. What is the formula for MCV here? Everybody calculated Menzer index. No. There was no Menzer index given to you at all here. I had just given hemoglobin, hematocrit and RBC. It cannot be thalassemia because RBC was only 3 million. 3 million is low. Thalassemia minor, RBC count will be high. Yes, correct. What is the formula for MCV? MCV is PCV divided by RBC count into 10. That will be the value of MCV. What is the PCV here? 36. 36 divided by RBC count is 3. So 12 into 3 is 36. So into 10, answer will be 120. I hope all of you can understand this point now. Answer here is MCV became 120. So I hope all of you can understand this. Examiner, if he has not given MCV, make your business to find the MCV in an anemia case. Examiner is expecting you to what? Calculate the MCV and answer. Okay. So in the given question, yes, and MCV will be 120. 120 is the MCV given there. Okay. Yep. So then it will be a macrocytic anemia. Okay. Next anemia, let us talk about hyperproliferative anemias. Let me talk about what are hyperproliferative anemias. Hyperproliferative are reticount more than 3%, right? Hyperproliferative anemia. In hyperproliferative, when reticount is more than 3, check whether it is a child or whether it is an adult. Age of onset is very important for a hemolytic anemia. Hyperproliferative are hemolytic anemias. Either they give you reticount more than 3 or examiner would be giving you jaundice as a history because that is also a manifestation of hemolytic anemia. Check for child or an adult. Child or an adult, isn't it? Yes, child will be inherited, adult will be acquired. It is important for us to know acquired and inherited. Now, once it is inherited, then if it is inherited or it is a childhood onset, check for clinical features. So what all clinical features can be there? So based on the clinical features, yes, based on the clinical features, okay, patient is having hemoglobinuria, oxidative stress, any age, child, adult, it can be any time. That is one history. Anybody, what are you thinking of this? In this, what are you thinking of? Okay, for the previous one you wanted pen. Okay, let me try to explain that with pen then. So, sorry. Yeah. So, MCV is equal to PCV divided by RBC count into 10. And that is a formula. Okay. So, in the given one, I had given you what? PCV was 36. That is why it became into what? Yes. Very good. Now, let us come back to this. Hyperproliferative anemias. In hyperproliferative, I said what? In hyperproliferative, we are checking child or adult. And in this, one history given to us was hemoglobinuria is present. The moment there is hemoglobinuria, what are you suspecting? If there is an hemoglobinuria, you are suspecting what? Intravascular lysis. Isn't it? You are suspecting intravascular lysis. Oxidative stress, any age. What are you thinking? Very good. Yeah, in the, sorry, my options were wrong. Not options were wrong. I wanted to give pure vegetarian by diet, that I forgot to mention in the question there. Yeah, in that both B12 and folate are correct. Next, one more. Patient is having splenomegaly, an inherited hemolytic anemia. Splenomegaly onset at birth. Is it thalassemia? Can anybody tell me? Is it thalassemia? Yes or no? Just yes or no. Y or N? No need to write. Nothing is to write here. Y or N? Splenomegaly onset at birth. Is it thalassemia? Yes, no. Yeah, very good. This is not thalassemia, because thalassemias will not manifest at birth. Very good. Very good. Very good. So now next, splenomegaly and hemolytic phases. You can add one word here, onset after 6 months. So you can just add that word. I have not added onset after 6 months. You can add this onset after 6 months. What is this one is what? This one will be thalassemia. This is your what? Spherocytosis. Very good. What about this one now? Patient is having splenomegaly plus minus, maybe mild splenomegaly, and patient is having vascular crisis manifestation. What are you suspecting? Yes, sir, vascular. Yes, very good. This will be your what? Okay. So now look at this. This will be your sickle. Okay, tell me now what are these four? The first one will be what? Hereditary spherocytosis. Second one is thalassemia. This will sickle, and this will be your what? G6PD deficiency anemia. Okay. If splenomegaly is there, peripheral blood smear will show spherocytes. What investigation can I do? Now, why am I giving these flowcharts? Because examiners nowadays are asking you what is the next line of investigation. Let me give you a question. Yes, I will come. Once I finish this chart, I'll ask you the question which came. Okay. Peripheral blood shows spherocytes. What investigation can you do? What is the next line of investigation here? Tell me. OFT. Very good. Osmotic fragility test. Osmotic fragility test. Next, okay, what is the treatment? Okay, diagnosis, hereditary spherocytosis. All of you got it correct now. Tell me what is the treatment for hereditary spherocytosis? Answer is a splenectomy. Treatment of choice is splenectomy. Isn't it? You remove the spleen. Yeah. Next is, if splenomegaly and hemolytic phases, onset is after 6 months. You are suspecting what? Thalassemia. Peripheral blood smear will show target cells and teardrop cells. Target and teardrop. And on HPLC, what do you see? On HPLC, that is the investigation of choice here, increase in hemoglobin F and decrease in hemoglobin A. HPLC, increased hemoglobin F, decrease in hemoglobin A. More than 90% will be HbF here. Hemolytic phases will be, yes, hemolytic phases will be chipmunk phases, or also called thalassemic phases. Frontal bossing, malar prominence, malocclusion of teeth. That is because of expansion of the medullary cavity, right? Yeah, this will be your thalassemia major. And what will be the treatment? Intermittent blood transfusion. Intermittent blood transfusion is the treatment. Yes, when do you give indication for BT in thalassemia? Yes, indications for BT in thalassemia, hemoglobin less than 10, we have to give blood transfusion. That is the indication. So in other anemias, indication for blood transfusion will be what? Severe anemia. In thalassemia, if it is less than 10, we end up giving what? Blood transfusion in thalassemia. Okay. Yes. Next is splenomegaly, plus minus I have written, and vascular crisis. what will be? Again, peripheral blood smear will show target cell and sickle cell, and investigation again is HPLC. Remember, HPLC is investigation of choice for both of your what? HPLC is investigation of choice, sorry. Just a minute. Yeah, sorry. HPLC is the investigation of choice for both what? HPLC is investigation of choice for both the hemoglobinopathies. Sickle and thalassemia, both of them are hemoglobinopathies. Okay. Yeah. So diagnosis here is sickle. Correct. This will be your sickle. Treatment for sickle. Anybody treatment for sickle? Treatment for sickle will be hydroxyurea. Anybody, what is the mechanism of action of hydroxyurea? Mechanism of action of hydroxyurea. See, whatever I am writing is not written in your book. Remember, so you also have to keep writing that. Whatever I am writing, whatever is printed, I will. Of course, they are already there in the book. Mechanism of action of hydroxyurea. 3 mechanisms are there. Let me write it here. Mechanism of action of hydroxyurea. Okay, MOA. I am writing on the top here. Mechanism of action of hydroxyurea. 1. Yes, correct. It increases HbF. 1 is it increases HbF. Second, it decreases DNA synthesis. And because it decreases DNA synthesis, is it good or bad? It is good. Why? Because it is suppressing the bone marrow erythropoiesis. Bone marrow erythropoiesis is suppressed. The third mechanism, it also induces vasodilation. 3 things. Vasodilation. Okay, so 3 things. Yeah. So because it induces vasodilation, it reduces sickling. It increases because it induces vasodilation, it reduces vascular crisis. Because it increases HbF, it reduces sickling, and it reduces DNA synthesis. Thus, bone marrow is able to produce less number of cells, isn't it? So 3 mechanism of actions of hydroxyurea. And again, also intermittent blood transfusion. Indication is the same here also. What is that? Indication will be hemoglobin less than 10. Okay. Yes. So the third one, what is the third one? Yes, I will be uploading the PDF also. I will be uploading the annotated PDF. Don't worry about that. So focus more on learning phase here. Yes. If you want to add into your book, you can add. Otherwise, yes, try to answer me. Okay. Peripheral blood, Heinz bodies and bite cells. Diagnosis, G6PD deficiency. G6PD deficiency anemia. Treatment for G6PD. Anybody, what is the treatment for G6PD deficiency anemia? Treatment, avoid oxidative stress. That is the treatment for G6PD deficiency anemia, right? So this is your inherited hemolytic anemias. Let us talk now the other side. Hemolytic anemia having in adult, acquired hemolytic anemia. Yes, acquired hemolytic anemias. In acquired hemolytic anemias, check for clinical features again. Clinical features, I look for, is there any autoimmune history? Why is that important? Because autoimmune acquired include your autoimmune hemolytic anemia and a PNH. So if there is an autoimmune history, like patient is having a thyroiditis or some other autoimmune disease, lupus or any of the autoimmune hepatitis or any other autoimmune disease given to us, right? And one more, look for history of hemoglobinuria, thrombosis and thrombocytopenia. Anybody remembers these triad? Patient having hemoglobinuria, thrombosis and thrombocytopenia. Triad of this is seen in which condition? Anybody remembers? Anybody, please. Yes, what is your diagnosis here? Yes, the diagnosis here will be what? Diagnosis here will be, yes, on this side. This side the diagnosis will be what? PNH. Okay. So if there is an autoimmune history or sometimes even drug history, I will add that as well. Autoimmune history or some drug history also. Autoimmune or drug history. Yes, sir. Can anybody tell me drug or autoimmune history? Some drugs can also cause autoimmune hemolytic anemia. Check for clumping or spherocytes. Clumping of RBCs or spherocytes. If clumping of RBCs or spherocytes are present, correct. So this will be your what? Then, of course, if spherocytes are there, do Coombs test. Look, observe this. There were spherocytes here also, and there are spherocytes here also. But in both of them, we are doing what? Different tests. This question came twice in exam. Please answer both the question. Question number 1, question number 2, and I will check in your chat box. I want you to answer both 1 and 2. What is the answer? Okay. Yes. Question 1. Let me say this came in inicet, I think 2020 it was, okay, or 2019 maybe. 23-year female presents to you with anemia. Peripheral blood smear shows spherocytes. What is the next line of investigation? Option, osmotic fragility test. Second option, Coombs test. Okay, 2 options. Only 2 options I am giving. Second question, last year NEET PG. Question, 8-year child presents with anemia. Peripheral blood smear shows spherocytes. What is the next line of investigation? Option, same, osmotic fragility and Coombs. Tell me now, what will be the answer for first and second? Yes, sir, please tell me what is the answer for first and second. I am seeing many of you are answering the first and second. Please tell me. The first one, very good. First one, you have to do Coombs test. Why Coombs test, sir? Why Coombs test in the first one? Very good. All of you got it right. Absolutely right. Absolutely. I love it. I love it. Yes, all of you are right. What is the second one? Yes, I am seeing that as well. Second one, osmotic fragility. Tell me, please tell me what was the keyword that you made a diagnosis based on. Keyword, the diagnosis was based on here. So, was it a child or was it an adult? Remember this. That is what you made a diagnosis. In the first question, I had given 23-year female. You do not suspect a spherocytosis there. You would suspect more of a autoimmune history there, right? 23-year female, more likely autoimmune. Second one, 8-year or 5-year child, that will be more, it will unlikely be autoimmune. It will be more likely to be what? Spherocytosis. Very good. Absolutely. All of you. Absolutely. Good. Great going. Yes, let us see now. Now, Coombs test is positive. Definitely we are thinking what? AIHA, autoimmune hemolytic anemia. Autoimmune hemolytic anemia. What is the treatment for autoimmune hemolytic anemia? Obviously, any autoimmune disease, we have to treat by what? Steroids, isn't it? That will be the treatment, or treat the cause. Steroids or treat the cause. If it is drug, you have to withdraw that drug that is causing AIHA, you withdraw that drug. Cephalosporins, penicillins can cause commonly. Yes, methyl dopa can cause. So many of them can be causing. Okay, what if Coombs negative? If Coombs negative, it cannot be autoimmune hemolytic anemia. Okay, so if there is no clumping and Coombs is negative, then it will not be autoimmune hemolytic anemia. Then if Coombs negative and patient is having peripheral blood showing spherocyte, very rarely you think of what? G6PD, because G6PD also can show spherocytes. Okay, yes. Next, what is this side? Already we have answered. Hemoglobinuria with thrombosis and thrombocytopenia. Diagnosis, yes. Pancytopenia also can be there. Diagnosis, PNH, correct? What is the investigation of choice for PNH? Flow cytometry. That is the gold standard. Diagnosis, PNH, isn't it? Yes, you already have answered it. Now, what is the treatment for PNH? Just we'll finish with that as well. What is the treatment for PNH? Monoclonal antibody to the complement, because PNH is a complement mediated destruction. Remember, it is not autoimmune. Okay, it is not autoimmune, complement mediated destruction. That's why we give monoclonal antibody to the complement. That is your eculizumab. That is the treatment. Eculizumab is the treatment. Yes, correct. On flow cytometry, you have to demonstrate negative to CD55 and CD59 there, isn't it? Yes, guys, great. Now, so you all have studied. I will give you some exam question. Let us look at the question now. So I am giving you an image centric, but we will end up what? Making a like it a exam like scenario. I will be giving you hints. Now, do not open your books here, okay? I mean, you can open your books. When I say you can write. Otherwise, try to answer. Anyway, I am going to give you an annotated PDF. Okay, keyword given to you. Patient is having a microcytic anemia, not responding to oral iron. Bone marrow aspirate is given. Option, megaloblastic anemia, sideroblastic anemia, iron deficiency anemia. 3 options I am giving you. Tell me now, what are you thinking of? Megaloblastic anemia, sideroblastic anemia, iron deficiency anemia. Which one are you thinking of? Yes, sir. So what is the keyword given? Microcytic anemia is the keyword. Megaloblastic rules out straight away. Not responding to oral iron. If it is, it can be a malabsorption. But however, bone marrow has been done. And what is the special stain done here? Anybody? The special stain shown to you is Prussian blue. That is the special stain that is shown to us here. Prussian blue. Yes, Prussian blue stain. Can anybody tell me now what are you seeing here? Yes, sir. you are seeing iron granules are seen. Iron granules are seen, and iron granules will appear what? Blue color granule. What is your diagnosis here? Diagnosis sideroblastic anemia. Correct. Diagnosis sideroblastic anemia. All of you are right. Yes. Diagnosis is sideroblastic anemia. Okay. Next question. Let us see this one now. So there is a biopsy given to us. Keyword: patient is having pancytopenia, no hepatosplenomegaly. Bone marrow biopsy has been given to us. So look at this. Patient is having pancytopenia, that has been given. That is a keyword for you. And there is bone marrow biopsy given. What are you seeing on bone marrow biopsy? Yes, I hope all of you are able to see what is your finding here. What is this cell? Of course, these are all adipocyte, only fat. You are seeing only fat. Fat only is seen. What is your diagnosis then? Very good. Aplastic anemia. This is not a dry tap. Remember, this is a bone marrow biopsy. This is your aplastic anemia. That is the diagnosis. Correct. Bone marrow aspirate of this patient will show what? Dry tap. What is a dry tap? No hematopoietic cells will be seen. No hematopoietic cells will be seen. Correct. Correct. Very good. Very good. Aplastic. This is a aplastic. Okay. Next, let us look at this question now. So there is an image given to us. Let us see how many of you can answer this. Yes. Very good. Image given to us. Stain name. Which one? The previous one. Prussian blue was the stain. And in aplastic, that was a H&D stain, normal H&D stain. Okay, this is a peripheral blood smear. Let us wait for the keywords. Keywords: patient has undergone ileectomy and he is having anemia. Tell me now, what are you thinking of? Ileectomy, anemia. What is your finding here? Yes, very good. Yeah, you know everything, you know. Yeah, I am just a messenger here. I just am revising your known facts. Your knowledge is absolutely good. Okay, look at this. What is your diagnosis? What is the finding? This is your cell. What are you seeing? Hypersegmented neutrophil. Isn't it? This is a hypersegmented neutrophil. And what is this cell? Anybody? Red arrow mark. Can anybody identify this cell now? This cell is teardrop RBC, or also called as a dacryocyte. Teardrop RBC, or also called as a dacryocyte. This will be is non-specific. Teardrop RBC can be seen in megaloblastic. It can be seen in megaloblastic. It can be seen in myelofibrosis also. It can be even seen in thalassemias. It can be seen even in thalassemias. Teardrop RBC. Very good. So what is your diagnosis here? Vitamin B12 deficiency. My diagnosis is B12 deficiency anemia. That is my diagnosis. Why B12 deficiency anemia here? Anybody? Because of ileectomy. That was my keyword. Yes. Same question. Patient is having celiac sprue. What is the diagnosis? Tell me. Same question. Celiac sprue. What is the diagnosis? Same question. Why no hepatosplenomegaly in aplastic anemia? Because there is no hematopoietic cells even in what? Spleen and liver there. Yeah. So if it was a celiac, then answer would have been what? Answer would have been folic acid. Very good. Okay. So let me see now. Let me give you this question. Look at this. 23-year female, peripheral blood smear. What is the next line of investigation? That is first question I am asking you. That is not there in the book. By the way, in the book there is a different question given. Please tell me now. 23-year female, this is a peripheral blood smear. What is the next line of investigation? What is the next line of investigation? Option, okay, I'll give you. Coombs test, flow cytometry, osmotic fragility test, HPLC. Yes, what are you going to do? What are you going to do? Next line of investigation. Good, absolutely good. Why Coombs test? What are you seeing on peripheral blood? Spherocytes. Very good. Okay, now I'm giving you another question. Newborn, jaundice, splenomegaly. That is the keyword. Can anybody tell me now? The actual question in your book. Tell me now. Newborn, jaundice, splenomegaly. So your answers is just a mix and match. I keep telling this. See, MCQs are really easy, guys. In MCQs, all that you have to do, I'll tell you there are multiple factions of MCQ. One is the question. In question, there will be multiple sentences also, 3-4 sentences. Another is the image. And the third are the options. These are 3 different sets that are given to you. You just have to what? Mix and match. So look at this. Same image. I am giving you some other history. What will be your diagnosis? What is the next line of management? Answer changes. Your answer will be osmotic fragility test now. And your diagnosis will be spherocytosis. Isn't it? Yes. So this answer diagnosis. What is the diagnosis here? Answer to that will be what? Hereditary spherocytosis. You will call it as Yes, hereditary spherocytosis, isn't it? Okay, can anybody now tell me, this patient was treated for malaria and after that he suddenly developed dark colored urine. Clinician is suspecting complication of malaria. Yes, sir. One of the complication of malaria, anybody remembers? Black water fever, we call it, right? Yes. What are you thinking of? What are you thinking of? Is it malaria? No, no, no. This is not malaria. What are you saying? Yes, correct. These are all, okay. Other history I am giving you. Another could be hemoglobinuria after starting antibiotics. Very good. All these are what? Bite cells. These are your bite cells. Very good. Very good. What is your diagnosis? G6PD deficiency. What is the mode of inheritance of this condition? I want to know. Mode of inheritance of G6PD deficiency. Anybody? Mode of inheritance. X-linked recessive. Very good. Very good. Arey Baba, ye to nothing, no history. Clinical images of the patient is given and the peripheral blood is given. Somebody was asking what is a thalassaemic phase. मैंने बोला था thalassaemic phase में तीन चीजें होते हैं. What are the three things? One is frontal bossing, malar prominence, even jaw can be prominent, and malocclusion of teeth. In this patient there is malar prominence. I hope all of you are able to see. Yes, there is a malar prominence. And also there is a malocclusion of teeth as well, isn't it? So diagnosis, this will be your what? Hemolytic phases. These are your hemolytic phases. And on the peripheral blood, can you tell me what is this cell? Arrow mark pointed. What is this cell now? What is this cell? Oh yes, what is this cell now? This cell is your what? Target cell. These are your target cell. And what is this cell here? Teardrop cell again, right? These are your target and teardrop cells. Target cell, and this is your teardrop. Target and teardrop. What is your diagnosis then? The diagnosis here will be what? Thalassemia. Probably it will be what? Major thalassemia disease. Right? Thalassemia disease. Yes, hair on end appearance on X-ray. You will see it on X-ray. Let us look. Okay, let me give you a question. Okay, patient presented with discharge from the finger. X-ray shows a suggestive of osteomyelitis. Peripheral blood smear is as shown. What will be culture of from the discharge is likely to be positive for which organism? Streptococcus, Staphylococcus, Salmonella, and something else, Brucella. Okay, diagnosis. Everybody is making a diagnosis first here. Okay, that is good. That is good. Nothing wrong. Very good. All of you are absolutely right here. The diagnosis is sickle cell. Very good. Salmonella will be your answer. Okay, I am simply asking you now diagnosis. Tell me what is this cell? Arrow mark pointed. This is your what? Target cell. Isn't it? This is your target cell. Then what is the other cell? Target cell. What is this cell? Sickle cell. This is your sickle cell. So what is your diagnosis? Sickle cell anemia. Diagnosis will be SCA. I am writing sickle cell anemia, and answer to my question, Salmonella. Okay. Patient is having, okay, nothing. Okay, let me give you a history. History has been given to us. Mycoplasma pneumonia patient. This is the peripheral blood smear examination. Patient with mycoplasma pneumonia. Yes, sir. Tell me now. This is a peripheral blood smear examination. Mycoplasma pneumonia, peripheral blood smear. What are you seeing here? Look at this. What are these? I am showing you. These are your clumps of the RBC. So diagnosis, this is your heme agglutination. What is your diagnosis? Very good. The diagnosis will be cold AIHA. It is a IgM mediated cold AIHA, or also called cold agglutinin disease. And mycoplasma patient, mycoplasma pneumonia will have this commonly. Yes, there is a clumping seen, isn't it? Yeah, it is a IgM mediated, correct? So diagnosis, IgM mediated cold AIHA, that is the diagnosis. Okay, next, let us look at the next images. Next images, let me, okay, next image. Okay, sir, you can have to write it down a little bit here. Okay, what is this pipette? Of course, everybody can identify what? RBC pipette. How do you identify this RBC pipette? In celiac deficiency, duodenum is affected. Yes, in celiac, I told you, dimorphic anemia will be because of iron and folate, both. Duodenum is affected, that's why iron deficiency will be there in celiac. Okay, tell me now. Last slide. Okay. So this was your heme agglutination. Diagnosis, cold agglutinin disease. That is a diagnosis if you want. Cold agglutinin disease. Cold agglutinin disease. Yes, very good. So how do I identify it as a RBC pipette? Two things. One, color of the bead. If it is a red color, definitely we are thinking of what? RBC pipette. Not only color of the bead, also look at the labeling. 101, up to 101 will be RBC, up to 11 will be WBC. Up to 11 will be WBC. Now tell me, sir, where do you count for platelets? Of course, WBC pipette will be for use for WBC, RBC pipette will be used for RBC. For platelets, which pipette will be used? For platelets, which pipette will be used? For platelet, it is the WBC pipette that we use. Okay, for platelet we use what? WBC pipette. For platelet we use WBC pipette. Because in platelet, especially if the platelet count is very low, we cannot be using the RBC pipette. Because if you are using RBC pipette, then what will happen? If you are using RBC pipette, there will be too much of dilution and will not be able to what? Get the correct count. Okay, so we use what? WBC. No, yeah, CAD, no, not PCH. PCH is IgG mediated cold. Agglutination, if it is found, it is not PCH. PCH will be IgG mediated. There will be no agglutination. It is a CAD if it is a agglutination seen. Okay, sorry, this one. Okay, where do we count? What is this now? This is your Newbar's chamber, isn't it? This is a Newbar's chamber used to what? Newbar's chamber for RBC count and the blood count basically. And in this Newbar's chamber, what do you count in this? Tell me now. So the four corners that I am labeling now, tell me, these four things that I have labeled or shown, here you do what? WBC count. I am doing a W, I am writing WBC count. Where do you count RBC, sir? Yes, sir. Where do you count RBC? In a Newbar's chamber, where do you count RBC? RBC will be counted in the center. Look at this. I am marking 5 chambers in the center. In the central chamber, there are 4 corner chambers. This is where you are counting RBC. And in the central chamber, this is where you count RBCs. RBCs will be counted in these 5 chambers. Now, platelets are, we use WBC pipette, but we use RBC chambers to count the platelet. RBC chambers to count the platelet. So remember, platelet count is done in RBC chambers, but we use what? WBC pipette there. And dilution factor will be 200 times. Dilution will be 200 times if you are using what? RBC pipette. And the dilution will be 20 times. Dilution is 20x, 200x if you are doing in RBC. If you are doing WBC, yes, it is a 20x dilution. Okay. Okay, next, look at this investigation. What are you seeing in this investigation here? This investigation is showing you what? Electrophoresis. This is your 2 investigations. One is electrophoresis. This is the electrophoresis and this is the HPLC. So in electrophoresis, what do you see? We see bands like this. It is a just a qualitative. It can tell us which hemoglobin is there. Okay, how to interpret electrophoresis? Look at this. There is positive mark given and there is a negative mark. That means the hemoglobin is moving. Different hemoglobin have different charge. That is why the rate of migration will be different. Okay. Yes. Dilution 20x and 20x for a WBC pipette and 200x for a RBC pipette. Obviously, you take up to 101. 0.5 will be the blood or both of the times. Take up to 101, discard 1 unit. So out of 100, 0.5 is blood. That is why you have diluted the blood 200 times. In WBC, take 0.5 blood, then fill it diluent up till 11 and then you end up discarding 1 again. So the terminal one will be discarded and there will be dilution factor will be 20 times there. Okay. Yeah. So now look at this. What is this? AFSC standards. So this is your first one is, this is your migration. This is your hemoglobin A. So look at this. I am labeling it A, hemoglobin A, and this is your hemoglobin F, this is your hemoglobin S, this is your hemoglobin C. So hemoglobin A2 and C cannot be distinguished on electrophoresis. That is why for thalassemia minor we always do one HPLC rather than doing electrophoresis for thal minor. But other condition we can do. Now look at this and try to interpret this. The first one. What are you seeing? So in this I am seeing only HbA, isn't it? Only HbA is seen in this patient. Tell me now, what is patient 1? Only HbA is seen in this patient. That means he is a normal patient, isn't it? Obviously he is a normal patient. Can anybody tell me patient 2, what hemoglobin is there in patient 2? And what is your possible diagnosis? In patient 2, there are 2 hemoglobins I am seeing. Yes, sir. Which are those 2 hemoglobins I am seeing? I am seeing both hemoglobin F and hemoglobin A. Both of them are seen. And I can appreciate here only F is more darker. That means amount will be more. But I cannot quantify how much more. But yes, I am seeing both hemoglobin. Can anybody tell me, is it normal to have? Yes, very good. This can be normally present in a fetus. Yes, correct. Fetus, this can be normal, or not only fetus, newborn also this will be normal. Both hemoglobin F, hemoglobin A are there in newborn. Let me say this fellow is 2-year child having anemia and jaundice. Tell me now, what are you thinking? This patient is having 2-year-old anemia jaundice. What are you thinking? And he is having HbF and HbA both. Yes, F and A both. This is not thal minor. Yes, correct. You can suspect this will be a thalassemia disease or major thalassemia you can call it, isn't it? Sorry. Yes. So you can suspect a thalassemia, major or a disease, not minor. In minor, A2 will be there, not F. F is present in major. Can you tell me the third patient now? What is the third patient showing you? Third patient is showing only one hemoglobin. What is this hemoglobin? HbS. So can anybody tell me the third patient, is he sickle cell trait? Is he sickle cell trait? Third patient, is he sickle cell trait? Or is he sickle cell disease? Is it sickle cell trait or sickle cell anemia? Very good. This is your sickle cell disease. SCA or sickle cell anemia. Can anybody tell me which is sickle cell trait in this? Let me label 4, 5, 6, 7. Tell me which one is a sickle cell trait in this. Which patient is sickle cell trait in this? Which patient is sickle cell trait in this? Yes, very good. Absolutely. Now look at this sickle cell trait. What are you seeing? Yes, sir. In this, there is a HbS and HbA. So what do I consider this? This will be a sickle cell trait. So this will be SCT I am writing. And what is sixth one? Tell me what will be sixth one. This will be HbSC disease. HbSC disease. What is HbSC disease? There is hemoglobin C and hemoglobin S in this. Seventh one, can you tell me what are you seeing in seventh one? Labeled already, F and S are seen. Where do you see hemoglobin F and hemoglobin S? Anybody? Hemoglobin F and hemoglobin C can be seen in sickle beta thalassemia 1. Sickle beta thal is a compound condition. One copy is having a sickle mutation, another copy is having a beta thal mutation. That is one condition. It could also be seen in patients on hydroxyurea. Patient on hydroxyurea. Sickle cell anemia patient. SCA patient on hydroxyurea. Yes, correct. On hydroxyurea, you can see both F as well as A there. Sorry, S as well as F, not F and A, S and F. Okay. Yeah. So what is the sixth? HbSC. You are seeing two hemoglobin. One is hemoglobin C, another is hemoglobin S. So both of them are abnormal. This is a HbSC disease. HbSC disease. So this was your electrophoresis. This is your hemoglobin electrophoresis, an investigation for hemoglobinopathies, abnormal hemoglobin. On the other side, you are having HPLC. So this is your HPLC. HPLC will be in the graph on the y-axis. This is the percentage or amount of hemoglobin. So on HPLC, on the y-axis, you are having one percentage of hemoglobin. And on the x-axis, this is called retention time, or these are also called windows for us. Okay, in this, look at this. Okay, at your level, forget this and forget G. So we have to know there are 4 or 5 F, A, A2, S and C. F, A, A2, S and C. Yeah, 4 is, this is a standard control all hemoglobin so that you can compare, right? It is just like this. 4 is again having all 4 hemoglobin. It is a control where we have to check, right? For that we are giving. Now, so in HPLC you are having F window, A window, A2 window. This is your A2. Sorry, just a minute. Yeah, this is your A2. Then you have S and you have what? C window. We call them windows because on the x-axis this is the time. There is a time, retention time we call it. So at different time intervals, different hemoglobin will be eluted. Different hemoglobin appear. So in this, look at this F, A, A2, S and C. F, A, A2, S and C. And you can see, let me say if I write this is your percentage, we can also quantify in HPLC. That is why gold standard is electrophoresis or HPLC for hemoglobinopathy. HPLC is the gold standard, isn't it? Right? Now, so important here is in HbA2. So in the HbA2 window that is there. In A2 window, both hemoglobin A2 will appear and hemoglobin E also appears in A2 window. So remember, in the A2 window where A2 is arriving here, this could be either A2 or it could also be what? Hemoglobin E as well. Remember, it could be either hemoglobin A2 or even hemoglobin E as well. Now, how do I differentiate whether it is A2 or E? That is why we quantify. If it is between 3.5 to 9, then we consider it to be HbA2. That is your thalassemia minor. Isn't it? It is thalassemia minor. If it is more than 9%, it is considered HbE. If it is more than 9%, it will be considered as hemoglobin E. Why do we have this scenario? Because both HbA2 and HbE will come at the same time. That is why to distinguish them, we use this. What is HbE? Anybody remembers what is HbE? HbE, there is a mutation in the 26th amino acid of beta chain from glutamate to lysine. Glutamate to lysine mutation is there. Hemoglobin E. In hemoglobin E. So I'll repeat again. In hemoglobin A2, this is called A2 retention window. In A2 retention window, there will be two hemoglobins appearing. One is hemoglobin A2 appears and another is hemoglobin E appears. Now, how do I distinguish between them? If it is less than 9, we consider A2. If it is more than 9, we consider hemoglobin E. And if it is 3.5 to 9, it is thalassemia minor. Less than 3.5 is not minor, normal people. Okay. A2 window is where A2 comes out or A2 is eluted. We use the word eluted, or where A2 graph appears. Where A2 graph appears. Hemoglobin E is, no, don't get confused. This is hemoglobin E. Hemoglobin C is, anybody, in beta 6th position, glutamate to lysine. In beta 6th position, glutamate to lysine is hemoglobin C. Hemoglobin E is in 26th position. Hemoglobin E is in 26th position. Okay, repeat number 2 here. Acha, in electrophoresis number 2, look at this. Hemoglobin F is there, hemoglobin A is there. Both of them are there. So that's why we are considering one. Hemoglobin F, hemoglobin A. It can be one normally, physiologically in a newborn, or it can be a thalassemia patient as well. It could be a thalassemia as well. No, didn't understand. Don't worry to interpret the graph. Forget about interpreting the graph. I am just showing you this is how HPLC graph appears. And for your knowledge, you should know only what? A2. Very important is A2. This is a normal. I am showing you all. This is a control graph. This is not a patient's graph. Okay. 7 is F and S are there. In patient, look at this. Compare, no, here only. See, this is the control. We are seeing A, F, S and C. So in 7, you are seeing what? This line, F is there, right? This is your F. And in this line, this is your what? S. So F and S are there. It could be a sickle beta thalassemia. What is sickle beta thalassemia? I told you. One of them will be sickle mutation. Another copy is having a beta thal mutation. Another could be a sickle cell anemia patient put on. Okay. Next. Yes. Next we will discuss approach to pancytopenia. Approach to pancytopenia. From this, for sure, one question in exam. So remember, I will repeat one question, iron deficiency anemia. Second question, pancytopenia. Pakka question, next line of management. And people end up confusing, so many confusion. Okay. Pancytopenia, first thing, look for clinical examination. Remember, what do I look for in clinical examination? Is there hepatosplenomegaly or no hepatosplenomegaly? In exam, examiner wants to give no hepatosplenomegaly. He gives no other significant finding, or rest of the examination is unremarkable or normal. That is the history that will be given to you. So, no hepatosplenomegaly or hepatosplenomegaly. Now, sir, if there is, in both of the condition, by the way, investigation for pancytopenia, we always do what? Bone marrow aspirate first, then biopsy if required. Okay. So, I am writing, first we are discussing pancytopenia with hepatosplenomegaly. I will do bone marrow aspirate or biopsy. Now, there will be 4 possibilities in bone marrow aspirate or biopsy here. What will be the 4 possibilities here? 1. Bone marrow is hypercellular with normal hematopoiesis. Bone marrow is hypercellular with normal hematopoiesis. Second one is dry tap. Bone marrow aspirate shows dry tap. But on biopsy, there is fibrosis. Is it aplastic? Tell me now. Is it aplastic? Bone marrow aspirate shows dry tap. And there is a fibrosis on biopsy. The third one is bone marrow shows infiltrative disease. And the fourth one could be bone marrow is hypercellular but with abnormal cells. Look at the first one, hypercellular with normal cells, and this is hypercellular with abnormal cells. Oh, yeah, very good. That question, my question was that aplastic anemia? No, for 2 reasons it is not aplastic anemia. 1, presence of hepatosplenomegaly. Second, presence of fibrosis on biopsy. In aplastic, there should be only fat seen. Correct? Very good. All of you are right. Absolutely right. Tell me now, what is the first condition? What is the first condition here? Hypercellular marrow with normal hematopoiesis. See, bone marrow is having normal hematopoiesis, but why is patient having pancytopenia? That means the killing is happening more. And the condition, hypersplenism. So what is hypersplenism? Spleen is excessively working, overworking spleen, because spleen is the graveyard of what? Cells of the blood. So that is what is, yeah, this is your hypersplenism. Hypercellular marrow with normal hematopoiesis. That means patient is having hypersplenism. Patient is having dry tap and fibrosis. This will be myelofibrosis. Either a primary myelofibrosis, which is idiopathic, or it can be secondary due to some drugs, some infection, etc. Third, if there is an infiltrative disease. What is infiltrative disease? Very good. I saw somebody using the word myelophthisis. What is myelophthisis? Something is infiltrating the bone marrow. There is no space for what? Normal hematopoiesis to happen. Yes, correct. That will be myelophthisis. So, if it is an infiltrative disease, you are suspecting a metastasis to the bone marrow. Metastasis to the bone marrow. Now, the fourth one, this is where the confusion starts. Patient is having a pancytopenia, patient is having a hepatosplenomegaly, and bone marrow is hypercellular with abnormal cells. So first thing I will look here will be morphology. Check for morphology of the cells. Yes, so please don't write anything here, understand here. Understand, all of you understand. For 1 or 2 minutes, please understand. I will tell you whenever you want to write, when you have to write, I will tell you that time. Okay, look for morphology first. On morphology, try to distinguish the cells. Are they mature cells or immature cells? Immature cells are blast. Mature cells will be peripheral cells, isn't it? Anybody now? If they are immature cell, hypercellular, abnormal, immature cells or blasts are there, of course, we are considering this is your what? Leukemia, by the way, isn't it? Now, if there are blasts which are proliferating in the bone marrow, which leukemia you are thinking of? Tell me, which leukemia? If there are mature cells, which leukemia? Yes, sir. So if there are immature, I am thinking of a acute leukemia. If there are mature cells, I am thinking of a chronic leukemia. Yes, correct. Now, so let me look for morphology first. Based on that, let me try to distinguish between immature or mature. Now, sometimes when morphology is equivocal, what is equivocal? Morphology is unable to distinguish. If the morphology is unable to distinguish between mature, immature, sometimes morphology cannot distinguish mature, immature, sometimes it cannot even distinguish what? Myeloid, lymphoid also. If morphology is equivocal, means cannot distinguish, I can use flow cytometry. Remember, if morphology is equivocal, I can use flow cytometry. Now, so once I know whether it is an immature or a mature, then check. Let us talk immature. Immature will be acute leukemia, as we know that. So if it is immature, check now again morphologically. Check whether it is a myeloid immature cell or a lymphoid immature cell. So based on the morphology, again we are trying to distinguish between myeloid and a lymphoid. So tell me now, I am seeing two different morphology. The first morphology, look at this, abundant granular cytoplasm in the blast, or rods are seen in the blast. What are you thinking of? What are you thinking of? The second condition, scant cytoplasm in the blast, no granules, no or rods. Yes sir, no granules, no or rods. What are you thinking of? Yes, tell me now. What is, and special stain also I have given you MPO, Sudan black positive here, and here it is what? Special stain, PAS positive. Can anybody tell me what are you thinking in the first and the second one now? Yes, the first one I am thinking more of myeloid. Second one I am thinking more of lymphoid. I again repeat this. What is that? Sometimes morphology is equivocal. It cannot distinguish between these two. Then again, can I use flow cytometry? Yes, I can use flow cytometry again. Yes, correct. The first one is a myeloid. Second one is a lymphoid. So now very important, that is the next line. See, if you know it is a myeloid, how do I know it is a myeloid? Either morphology will tell me it is a myeloid. If morphology is not definitive, then I have to use what? Flow cytometry to arrive at a diagnosis of myeloid leukemia first. Once I know it is myeloid, I do not do flow cytometry further. So remember, for subtyping of myeloid, we do not do flow cytometry. For subtyping of myeloid, I start with cytogenetics first. Fish is the first investigation I will be doing. Okay, once I do fish, then in fish there can be two possibilities. Fish cytogenetics positive, negative. What do you mean by positive? I am able to see some translocations, or I am not able to see some translocations. So if fish is positive, then we will call it AML with cytogenetic abnormality. That is one of the category of your WHO, if you remember. AML with cytogenetic abnormality. Next, if fish is negative, okay, for myeloid markers, MPO commonly used, there are CD117, 13, 33, so many of the markers are there. MPO you remember, important marker. Okay, so if cytogenetics is positive, AML with cytogenetic abnormality. If cytogenetics is negative, then what do I do? If there is no genetics, cytogenetic mutation, cytogenetic seen, then check for PCR. Do PCR or sequencing. Do PCR or sequencing. And when I do PCR or sequencing, there are two possibilities. I can find some mutations like CEBPA mutation or a RUNX1 mutation or a NMP1 mutation or no mutation. So if I find mutation, I will call it a AML with these mutations. AML with mutations. If I don't find any mutation, it will be called AML NOS. What is NOS stands for? Not otherwise specified. Not otherwise specified. AML NOS. Okay. Yes. Next. On the other hand, if the cytoplasm is scant, there are no granules, no or rods. What are you thinking? This will be thinking of what? Myeloid or lymphoid? Myeloid or lymphoid. Example of cytogenetic abnormality: translocation 821, 1517, inversion 16. These are cytogenetic abnormalities. Okay. Any translocations. Now tell me, this will be a what? Lymphoid. And for lymphoid, do I do genetics or do I do markers? For lymphoid, we don't do genetics. For further subtyping, we do flow cytometry. So for lymphoid, we do flow cytometry for further subtyping. So for lymphoid, what flow cytometry markers? We look for CD3, TDT, CD10, 34. If they are positive, what is your diagnosis? If these are positive, then the diagnosis is T cell leukemia, acute leukemia. and 19, 20, 10 TDT 34 positive, that will be a B cell, isn't it? So TALL and we have a BALL, TALL and a BALL. I hope all of you understood this side now. That is your what? Acute leukemias, isn't it? ये तो हो गया acute. These are your acute leukemias. I will give you questions. You will understand when to use what. Okay. Next. What if there is mature morphology? Morphologically, the cells are abnormal, but they are mature cells, not abnormal cells. If they are mature, further again based on morphology, try to divide them into what? Lymphoid or myeloid cells. Same thing again. See, even in immature also, we try to divide them into myeloid and lymphoid. Here also, we are trying to divide them into lymphoid and myeloid. If it is lymphoid, do flow cytometry again. If it is myeloid, don't do flow cytometry. For myeloid, again do fish PCR. So remember, for myeloid subtyping, whether acute or chronic, we always do what? Genetic testing. For lymphoid subtyping, we do what? Flow cytometry. Okay? Yes. But however, this word you should remember. Use flow cytometry if morphology is unequivocal. Means you do not know whether it is myeloid or lymphoid. First use flow cytometry. After that, if it turns out myeloid, then do what? Genetics. After that, if it turns out lymphoid, then do continue with flow cytometry only. Yes. Next. Next is the third part here. What is the third part here? Okay. There is no hepatosplenomegaly. Okay. Flow cytometry. What will this be, by the way? Okay. We'll write them. Okay. No hepatosplenomegaly. What is no hepatosplenomegaly? Pancytopenia without hepatosplenomegaly. Check for bone marrow aspirate biopsy again. Now 3 possibilities here. Hypocellular marrow with a dry tap. Hypocellular or acellular marrow with a dry tap. Can anybody tell me what is that? Acellular marrow with a dry tap. What are you thinking of? Another possibility is hypercellular marrow with dysplasia in the bone marrow. So look at this. No hepatosplenomegaly, pancytopenia, hypocellular or acellular marrow, dry tap. What is the diagnosis? Aplastic. Hypercellular with dysplasia. What is the diagnosis? Hypercellular with dysplasia. What is the diagnosis? Yes, very good. What is this condition? Hypercellular with dysplasia. What is your diagnosis? Very good. All of you were right. This condition is aplastic. What is this condition? What is this condition? Hypercellular with dysplasia. What is this condition? Very good. Myelodysplastic. Then one more. Patient is having hemoglobinuria and thrombosis and pancytopenia. Patient is having pancytopenia, hemoglobinuria, thrombosis. PNH. Very good. 3 conditions. These are aplastic, PNH, and of course this is MDS. We have to again do cytogenetics and that is cytogenetics. Fish. Commonly we do fish. Okay. So just please add this one word which is missing in your flow chart now. See, in your lymphoid, we said flow cytometry. What is your diagnosis? CLL here. That's it. I just have to add that. And for myeloid, we are doing fish and PCR. For Philadelphia and JAK2, and diagnosis will be either a CML, polycythemia vera, or a ET commonly, isn't it? CML, PCV, or ET. Any one of these 3. I hope all of you understood now. Approach to pancytopenia, isn't it? Approach to pancytopenia. All of you clear with the approach to pancytopenia? Okay, I will come to this part subsequently. Just a minute. Okay, before this, I will give you a question. Let me see how many of you can answer. How many of you understood this? Why no hepatosplenomegaly in this condition? In this condition, there are no stem cells in aplastic anemia. In MDS, there is adequate space in the bone marrow. Even in PNH, there is adequate space in the bone marrow. So there is no hepatosplenomegaly. Hepatosplenomegaly happens whenever there is no space in the bone marrow and your stem cells are normal. Okay, for that both should be. Okay, let me give you a question. I was asking you. This question came. Let me see how many of you can answer. Okay, a 60-year female presents with easy fatigue. Peripheral blood smear shows TLC of 60,000. Differential count, 80% of them are mature lymphocytes. What is the next line of investigation? What is the next line of investigation? Option, fish PCR. 2. Fish, PCR, cytogenetics. 3 options. What is the next line of investigation? 60-year female. Yes, what is your diagnosis? 60-year female presents with easy fatigue. Peripheral blood smear shows TLC 60,000. Differential count 80% mature lymphocytes. What are you thinking? So I have given you 80% mature lymphocytes. Yeah, very good. You will not do cytogenetics. Why? Again, I will tell you. Patient, morphologically, tell me, morphologically, what are you saying? You are suspecting pancytopenia is there. So you are suspecting a leukemia. Morphologically, what are there? Proliferation of immature cell or mature cell? Mature lymphocytes. And if they are lymphoid, already told to us it is lymphoid, then you have to do what? Flow cytometry, isn't it? Yeah. One more, let me give you. Let me see how many of you can answer this. 55-year male presents with hepatosplenomegaly, pancytopenia, hemoglobin 10, okay. TLC I'll give. TLC is 28,000 or 1,28,000. TLC 1,28,000. Differential count, important ones I'll give you. Basophils are 10%. Neutrophils are 20%, lymphocytes are 20%, monocytes maybe a little bit more, 30%, but basophil 10%, eosinophil 5%. Tell me, what are you suspecting? Clinically, what are you suspecting here? First, I want to know clinically what are you suspecting? What is the next line of investigation? Same options again. What is that options I'll give you? Genetics or flow cytometry? Tell me, what do you do? Cytogenetics, flow cytometry, which one? Yes, sir. In this, what do you do? Very good. You are suspecting a CML. Why you are suspecting a CML? Basophils are increased here. Morphologically, mature cells, which mature cell? Lymphoid or myeloid? Myeloid are increased. So that's why I will do what? Cytogenetics. Either FISH or even I can do PCR for Philadelphia. Specifically, if they ask you, I am suspecting CML, I will be doing FISH or PCR for Philadelphia. Okay, one more question I'll give you, so that this is for trial, so that you do not make this mistake. Both these questions were asked in exam, by the way, whatever I gave you. The third question, let us see how many of you can answer this. Patient presents, 35-year male presents with pancytopenia, hepatosplenomegaly. Bone marrow examination shows large cells with abundant granular cytoplasm and occasional OR-ROTs. 25% of such cells are there in the bone marrow. What is the next line of management or next line of investigation? Tell me, is it flow cytometry or is it yes sir, is it flow cytometry or cytogenetics? What do you do next? You are suspecting AML here. Very good. If you are suspecting, okay, again I'll repeat. Patient pancytopenia, hypercellular marrow, morphologically immature cells, large cells are immature, having abundant granular cytoplasm or rod. You are suspecting myeloid. What is the next line of investigation? FISH or cytogenetics. Yes, very good, very good. Okay, let me give you one more. 35-year male presents with pancytopenia, hepatosplenomegaly. Bone marrow examination shows hypercellular cells, hypercellular marrow, and further morphology, these look large and immature. 25% of them are there. They are large and immature. Morphologically, there are no granules. Morphologically, there are no granules, but abundant cytoplasm is there. And pathologist is unable to distinguish myeloid and lymphoid on morphology. I am just giving you this. And then what is the next line of investigation here? Tell me, what is the next line of investigation? What is the next line of investigation? Yes, very good, very good. You are doing what? Flow cytometry. Why? If morphologically you are unable to distinguish lymphoid or myeloid, you don't go for what? Okay. Now let me tell you. Yes, very good. Now continue the same question. In the same question, morphology was unequivocal. You did a flow cytometry. The cells are positive for MPO, negative for CD3 and CD19. On flow cytometry, yes, cells are positive for MPO, myeloperoxidase, negative for CD3, CD19. What is your next investigation here? What will be your next investigation here? Will you continue with flow or will you do cytogenetics now? Tell me. Yes, sir. What do you do? Now your answer will be FISH. Why? The moment I say they are MPO positive, negative for CD3. CD3 is a T cell marker. CD19 is a B cell marker. That means it is not a lymphoid. It is myeloid. If it is myeloid, what is the investigation I will do? Myeloid, I do what? Cytogenetics. I hope all of you are understanding now. Yes, very good, very good. Yes. Maza aa raha hai sabko? All of you are having fun. So this is the biggest, elephant in the room. People end up fearing this. This is one flow chart. For sure, expect this question in exam. NEET PG and INICET both. and many people make mistakes here. Do not make mistake. Okay, what question they are going to ask you, you should be knowing exactly. Okay, sir. So this is over. Now next we go to the lymphadenopathy part. Okay, one more flow chart. So this is RBC is done, 2 flow charts, WBC 2 flow chart, bleeding disorder 2 flow charts. We'll finish off whole of hematology here. Okay, so lymphadenopathy. Patient is having lymphadenopathy. What do I do? If patient is having lymphadenopathy, of course, apart from infectious and other condition, I am suspecting a lymphomas. We are only talking about what? Lymphomas here. Okay. So now lymphomas could be 2 types, Hodgkin, non-Hodgkin, right? So clinical features. Look for clinical feature, clinical examination and on microscopy. On clinical examination and microscopy, yes, there could be a generalized lymphadenopathy. There could be a generalized lymphadenopathy or there could be a regional lymphadenopathy. So look at this generalized lymphadenopathy. Yes, generalized lymphadenopathy and regional lymphadenopathy. Generalized lymphadenopathy, extranodal organ involvement positive and numerous neoplastic cell on microscopy. Clinically, regional lymphadenopathy, extranodal organ negative, occasional neoplastic cell. Yes, sir. Tell me, what are you thinking of? What are you thinking of? First and second, please tell me. Yes. What are you thinking of in the first and the second one? Yes, very good. This is your what? Non-Hodgkin lymphoma and the other one is your what? Hodgkin lymphoma. Let us write. So Hodgkin and non-Hodgkin. Okay, first let us do Hodgkin, easier one. Hodgkin lymphoma, next look for markers. What markers I look for? 4 marker, 15, 30, 20, 45. Most specific, okay, will not get into that. So CD15, CD30, CD20, CD45. 2 possibilities are there. One could be CD20 positive and CD45 positive. Another could be CD15 and CD30 positive. Tell me now, which is what? 20 and 45 positive. What are you suspecting? 20, 45 positive. Nodular lymphocyte predominant Hodgkin. What cell on biopsy? Tell me, what is the morphological cell that you get? What is a morphological cell? Let me see in the chat box. Morphological cell. Yes, sir. In this, what is a morphological cell? This is your popcorn cell. Popcorn cell. Very good. The diagnosis is nodular lymphocyte predominant Hodgkin lymphoma. Nodular lymphocyte predominant Hodgkin lymphoma. What is the other side? This is called a classical Hodgkin lymphoma and this will show what? Owl eye appearance. That is your Reed-Sternberg cell. Pardon me for the spelling mistake. Okay, R-E-E-D, Reed-Sternberg cell. Okay, yes, this is your Reed-Sternberg cell. Popcorn cell, Reed-Sternberg cell. So this is your classical Hodgkin. The other one is classical. Okay, Hodgkin, not much of confusion. Non-Hodgkin, lot of confusion. Let us focus again. No need to write. Yes, keep following your book and keep focusing onto the class. Keep all your ears to my voice only. Okay, so now if it is a non-Hodgkin, what do I do? Let me write markers you should look for. Let me write this marker for a non-Hodgkin. Hodgkin is easy, everybody knows. For non-Hodgkin, look for the marker. Please write down in your flowchart as well. Look in the following order. CD3, CD20. This is the first marker, group of marker I look for. Now, if it is CD3 positive, it will be definitely T cell. If it is CD20 positive, it is what? B cell. We all know this, isn't it? Now, if it is CD20 positive, then we look for CD5, CD10, CD23 in order. So, if it is 3 positive or 20 positive, first thing, once it is 20 positive, then look for 5, 10 and 23 in order. I am telling you, you look for them in order. Okay. Yes. Yes, Dams Jaipur connection lost. What just now? You just tell me what you want me to repeat. Then I can do that. Yes. So non-Hodgkin lymphoma. Yeah, lymphadenopathy. Clinical examination, microscopy. Clinical examination, regional lymph node, extranodal organ negative, no, and occasional neoplastic cell Hodgkin. In Hodgkin, 15, 30, 20 and 45. We are checking for them. 20, 45 positive, popcorn cells are seen. That is nodular lymphocyte predominant. 15, 30 positive, they are your Reed-Sternberg cell and that is your classical Hodgkin lymphoma. Okay, so non-Hodgkin lymphoma is there. Then what? Do IHC, that is marker, further markers. I told you what should be the markers that you should look for. First set of marker, look for 3 and 20. So 3 and 20, I'm also adding 19 as well. I'm just adding 19 here, but we commonly do 20 only. Okay. 19 is the most specific marker for B cell. That's why I'm adding 19. Okay. So 3, 19, 20, I have written 3. Yes, 3, 19, 20, but I'm using 3 and 20 commonly. Okay. Tell me now, 3 positive. What is it? T non-Hodgkin. CD3 positive, T non-Hodgkin. 19, 20 positive. 19, 20 positive, BNHL. 1920 positive, BNHL. 1920 BNHL. Okay, so TNHL dead end, there are hardly few of them. BNHL important for us. And in BNHL, what did I tell you in order? What should you look for first? CD5. Let me look for CD5. CD5, two possibilities, positive or negative. CD5 positive, CD5 negative. Tell me if it is positive. Let us handle positive first. CD5 positive. Anybody remembers what are the DDs for CD5 positive B cell lymphomas? CD5 is a marker for naive B cell. Which neoplasms arise from naive B cell? 2. BCLL SLL and mantle, isn't it? BCLL SLL, mantle, pre-germinal, correct? BCLL SLL, mantle. So if it is CD5 positive, check for CD23. Check for 23. Usually 23 positive, negative. Positive or negative. 10 also you can check, but 23 is important. 10 will be immaterial here. Positive or negative. Can anybody tell me? 5 is already positive. If it is 23 positive, what's your diagnosis here? Batao. What is the diagnosis? What is the diagnosis? 5 positive, 23 positive. What are you thinking of? BCLL SLL. Very good. That is your BCLL SLL, right? Correct. BCLL SLL. CLL stands for chronic lymphocytic leukemia. SLL, small lymphocytic lymphoma. BCLL SLL, isn't it? Now look at the other side. So it is CD5 positive, but CD23 negative. Tell me now, what are you thinking? CD23 negative, what are you thinking? CD23 negative, you're thinking mantle cell lymphoma. Very good. But I want to do one more marker, cyclin D1. Anybody remembers? Cyclin D1 is a marker for what? Mantle cell. If it is CD23 negative, I'm sure it is a mantle cell, but I'm still doing cyclin D1. Why? Cyclin D1 could be positive or could also be negative. Tell me now, if cyclin D1 is positive, definitely it is a mantle cell lymphoma. What if it is cyclin D1 negative? Now look at this. Patient's lymph node biopsy, CD5 positive, 23 negative, cyclin D1 also negative. Tell me now, what are you thinking? Yes, sir. What is this? What is this condition? Cyclin D1 negative. What is this condition? Tell me. What is this condition? Very good, very good. You are suspecting a cyclin D1 negative mantle cell lymphoma. What marker will you do? You will be doing, write this, not written in your book, SOX 11. SOX 11 positive. There will be SOX 11 positive and that will be called as what? Cyclin D1 negative mantle cell lymphoma. Very good. SOX 11 is the marker that we'll be doing. That will be cyclin D1 negative mantle cell lymphoma. Done all of you? Good, good. CD5 वाले हो गए, ठीक है? अच्छा, next we will discuss CD5 negative lymphomas. CD5 negative could be many of them. I will look for 10 and 23. I told you already we should look for in order. पहले 5 देखो, उसके बाद 10 and 23 check करो. So 5 is positive, only check 23 enough. 5 is negative, check for 10 and 23. Now what could be the possibilities in 10 and 23? Both positive, both negative, one of them positive, right? Yes. So 3 possibilities here. What are those? 10 positive, 23 negative. Anybody remembers 23 is also marker for what? CD10 is a marker for precursor cell and germinal center cells. Precursor cell and also germinal center, CD10. CD23 is a marker only for germinal center and mantle, BCLL SLL, by the way, that is an aberrant expression. So CD23 is a marker for germinal. So this is 10 positive, 23 negative, meaning what? 10 can be positive in both precursor and germinal. 23 will be positive in germinal. That means it is not germinal. So this is a precursor cell. Another could be 10 positive, 23 positive, both positive. Can you tell me what is this now? Is it a precursor or is it a germinal? This will be a germinal because both are positive. And it could be both negative. What is this now? Can anybody tell me? Both negative. So 3 possibilities are there here. Yes, very good, very good. So the first one, 10 positive, 23 negative. What are you thinking? This is, I told you, precursor. Confirmation of precursor can be done by TDT. TDT is also marker for precursor. And if it is positive, definitely it is a BALL. It is B because already it was what? 19 and 20 positive, isn't it? BALL. Now, 10 and 23 positive. Then what? 10 and 23 positive, check for B symptoms. Anybody knows what are B symptoms? B symptoms are symptoms of high grade lymphoma, isn't it? B symptoms could be 2, positive, present, absent. B symptoms, fever, weight loss and night sweats, can be present, can be absent. If B symptoms are absent, you are thinking of a low grade lymphoma, isn't it? And check for BCL2, another important marker. This question came in last year, NEET PG, BCL2. BCL2 positive, low Ki67 index, we are thinking follicular lymphoma. Follicular is a low grade. If B symptoms are present, we are thinking a high grade, isn't it? And if it is a high grade, we are thinking a high grade arising from germinal center, because 10 and 23 are positive means germinal center. Could be a Burkitt, could be a diffuse large B cell. Check for Ki67. Anybody remembers? Burkitt lymphoma has a Ki67 almost 100%, we say. So Ki67 more than 95% or less than 95%. More than 95, almost 100%, that will be Burkitt. That will be Burkitt. Less than 95 but high, diffuse large B cell. B symptoms will include fever, weight loss and night sweats. They are features of high grade lymphoma. BCL6 is also marker for germinal center. So you can just add here, BCL6 is also marker for germinal. It will be positive in germinal center. BCL6. Now 10 negative, 23 negative means it is not precursor, it is not germinal, and it is also 5 negative. That means it is not even one pre-germinal. That is neither precursor nor pre-germinal nor germinal. This will be a marginal. So this is your marginal zone lymphoma, maltoma. Yes, Ki67 is for proliferation. Proliferation index. Very high, 100% proliferation. We are thinking Burkitt. Clear all of you? Clear all of you? Lymphomas. Approach to lymphoma done in one flow chart. Over. This is your lymphoma. Just have this approach. It is very easy to, and your markers becomes your friends now. They are not your enemies anymore. All of you understood? समझ में आ गया सबको? Okay, NHL repeat. Somebody is asking. Quickly, I will recapitulate NHL. I told you पहले क्या चेक करोगे? CD3 and 20. 3 पॉजिटिव है तो T सेल हो गया, 20 पॉजिटिव है तो B सेल. अच्छा 20 पॉजिटिव है तो 3 आपको ऑर्डर में देखना है. पहले CD5 देखो, देन 10 देखो, देन 23 देखो. पहले 5 देख रहे हैं. 5 में क्या होगा? पॉजिटिव या नेगेटिव या पॉजिटिव, राइट? 5 पॉजिटिव अगर हो गया, डीडीज आपके दो ही हैं, मेंटल एंड BCLL SLL. इमीडिएटली चेक 23. 23 अगर पॉजिटिव निकला, BCLL SLL. 23 अगर नेगेटिव निकला, then it will be what? Yes, 23 अगर नेगेटिव निकला, then it will be what? Mantle. Check for cyclin D1. If it is positive, definitely mantle cell lymphoma. If it is negative, it is also mantle cell, but it will be cyclin D1 negative mantle cell. But just do SOX11 here. Now, if CD5 is negative, then what? I told you check in order 10 and 23. Check 10 and 23. 10 positive, 23 negative means it is a precursor. Both positive means it is a germinal center. Even BCL6 will be positive in germinal center. And both negative means it is a marginal. So germinal center could be low grade like a follicular, which will have BCL2 positivity and also low Ki67. Proliferation will be low. And B symptoms will not be there. Achha, B symptoms, examiner will not give you no B symptoms. He will give you, patient is having lymphadenopathy, rest of the examination is unremarkable. Means does he have weight loss, fever, night sweats? No. If they were there, it cannot be unremarkable, isn't it? Yeah. So unremarkable जब भी देंगे examiner याद रखो ये asymptomatic होगा या no hepatosplenomegaly. This is what examiner is hinting to you. Now, if B symptoms are present, it is a high grade. Then look for Ki67, almost 100%, make it Burkitt. Anything less than 100, I would make it what? I have given you 95%, but Burkitt 100%. आपके level पे 100% ही देंगे. CD10 is for precursor and germinal center. Okay, please tell marker for germinal, precursor, etc. Okay, precursor marker CD10 TDT. Pre-germinal marker CD5. Germinal marker CD10, CD23 and BCL6. That is the germinal marker. Post-germinal, no specific markers are there. It is the exclusion, diagnosis of exclusion. Easy में आ जाते हैं, ठीक है? So now you can relax a little bit. You don't want to use too much of your gray matter as of now. Let us start with simple. Cells. Identify the cells. Look at this. This is a lymphocyte. Size of the cell. Lymphocyte chota hoga. Cytoplasm will not have granules. Cytoplasm will be scant. That is your lymphocyte, right? This is your monocyte. This is the largest cell. Very large. Almost more than double the size of lymphocyte in the blood. And can have some very vague granules. Okay. Slight complexity. Eosinophil. Bilobed nucleus and bright pink granules. Eosinophil. Basophil थोड़ा सा छोटा होगा, इसमें भी स्पेक्टेकल जैसे न्यूक्लियस मिल रहा है. ओके, इवन eosinophil will have difference. अच्छा, ये काला काला चश्मा, ये है आपका पिंक पिंक चश्मा, राइट? दैट इज व्हाट इज द डिफरेंस. Yes, I will take questions, don't worry. Okay, so this is a pink and blue. Difference between them, both of them will have one spectacle like. Only thing is granules. Look at the granules, bluish black granules. Think of baso. Then neutro. Neutro will be what? Polymorph. Multiple lobes will be there, right? Okay, let us look at the next one. Okay, try to identify this now. Let us look at this is your bone marrow aspirate and biopsy needle. How do I know aspirate needle? You have to look at the bottom of the needle. Carefully look. Let me see if I can zoom it. No. So carefully look. There are two holes that you are seeing. In aspirate, there will be holes seen here. Aspirate needles will have holes. Biopsy needle doesn't have a hole. Remember this. So aspirate needle will be having, yes, okay, and biopsy, this is the biopsy needle. Okay, biopsy needle doesn't have holes. Remember this. This is how you identify. Biopsy needle is almost like your true cut biopsy needle. Normal true cut biopsy भी ऐसे ही दिखता है आपका, right? Yes. Okay, sir. This is a lymph node biopsy. Let me give history. Patient history: abdominal mass, fever, night sweats. Okay, tell me. Abdominal mass, fever, night sweats. I will give you markers also. Let me say it is CD 20 positive, CD 5 negative, 10 positive, 23 positive, BCL 6 positive, KI 6700. बताओ क्या है? Burkitt. Very good. Now approach these marker. Please tell me. Approach these marker. Approach these marker. Okay, look at this. Approach this marker. I am writing KI 67. I am changing now. I am changing my question. Carefully look at this. Now tell me what is your diagnosis. This is the image. These are the markers that I have done. Yes, very good. What is your appearance that is given here? So if I am giving 90%, then do not make Burkitt lymphoma. Answer will be diffuse large B cell lymphoma. Starry sky can be seen even in diffuse large B cell also. Very good. Yes, correct. So if it is given as what? 100%, then answer will be what? Yes, if it is 100%, then the answer is Burkitt. Correct. Okay. So what is your diagnosis? What is a mutation? That is a question asked. So leave this question. Okay, let me make it 100 only, because then you'll ask, okay, what is your diagnosis here? Burkitt lymphoma. What are you seeing? What is the appearance? Appearance is starry sky. Starry sky appearance. What is starry sky appearance? Look at this. The background blue color cells are the lymphoma cells, and in between you are seeing these are macrophages. क्यों ऐसे macrophages मिलते हैं? Why do you get macrophages? Burkitt being a very rapidly proliferative lymphoma, because rapid proliferation है, तो क्या होगा? The blood supply cannot match the growth of the lymphoma cell, and that is the reason why there will be necrosis happening. Cells will die because blood supply is not matching the growth of the cells. Because necrosis, dead cells have to be phagocytosed. Macrophages come to phagocytose. So you are seeing there will be neoplastic cells, there will be some necrotic cells also on higher power, and you are seeing one macrophages. That is why starry sky can be seen in any high grade lymphoma. Need not only be in Burkitt. Yes, of course, classically in Burkitt, but can be in any high grade lymphoma. What mutations will be seen? Yes, mutation will be translocation. 3 translocation. Anybody remembers? Translocation 28, 814, translocation 28, 814 and 822. 3 translocations you will be seeing, isn't it? 28, 814 and 822, and all of them will lead to proto-oncogene mutation, CMYC mutation. Correct? CMYC mutation will be there. Okay, sir. Tell me now, what will be the markers in this case? I want to know what will be the markers in this case. Okay, what is that hint given to us? Let us check. Cervical lymph node has been given. What appearance is this? Owl eye appearance. Correct? The diagnosis. This is your owl eye appearance. RS cells. Diagnosis. These are RS cell. Can anybody tell me what markers will be there? 15 and 30 positive. What is the etiology for this? Epstein-Barr virus. Diagnosis. Classical Hodgkin lymphoma. Classical Hodgkin lymphoma is the diagnosis, isn't it? Yes, absolutely. Everybody is answering now. Okay, so these are your RS cells, owl eye appearance. Okay, tell me now. 60-year female, peripheral blood is given to you. What is the next line of investigation? I want to know what is the next line of investigation. Of course, diagnosis. What are you suspecting? What are you suspecting in this? Yes, sir. What are you seeing here? Okay. Elderly anemia recurrent infection has been given to us. Question asked is diagnosis, and also I am asking you what is the next line of investigation. What are you seeing? This is your one lymphocyte, mature lymphocyte, and these are your smudge cell. What are smudge cells here, sir? Smudge cell, when lymphocyte, when you are doing a smear of a CLL, the cell of the CLL is very fragile. Cytoplasm breaks, nucleus gets crushed, and these are all purple appearing cell. These are all crushed nuclei of the leukemia CLL. So diagnosis, you are doing suspecting one CLL. Very good. And what is the investigation I asked you? Flow cytometry. You have to be doing flow cytometry here, isn't it? On the blood only. You need not do bone marrow also here. Why? Because already neoplastic cells are there in the blood. Do flow cytometry on the blood only. Okay, this is your smudge cell. Okay, let us see one more question. 4-year-old fever. And this is a bone marrow aspirate. 25% of such cells are seen in the bone marrow. Tell me, what is your next line of investigation and what is the likely diagnosis? Both again. Yes, sir. What are you seeing here? What are you seeing here? Cells are small or large? They are mature lymphocyte or... Okay, first, large cells. Why large? Compare with the RBC. Look at this. This is the size of the RBC. This is almost 3 times that of what? RBC. This is almost 4 times that of RBC, isn't it? So definitely these are what? Blast. I can identify they are blast because they are what? Large cell. Now, once I know morphologically I am able to identify they are blast, then I have to identify myeloid or lymphoid. Abundant cytoplasm, scant cytoplasm, scant cytoplasm. Granules, no granules, no granules. Then what do? I am thinking of a, yes, my suspicion is lymphoblast. So if my suspicion is lymphoblast, what is my diagnosis? I am suspecting ALL. So my diagnosis is ALL. What investigation? Fish or flow cytometry? No, not fish, not fish. I am not, I will do flow cytometry. This is not AML. This is not myeloid. No granules, no rods. I am suspecting lymphoid. So this will be flow cytometry. Okay, let us see this. Keyword, 55-year backache. And this is the bone marrow examination. What are you seeing? Okay, look at the cells here. What are the cells? Cytoplasm of the cell is very bluish. And look at the nucleus, eccentric nucleus. Cytoplasm blue, eccentric nucleus. And this is your MOT cell that you are seeing. What is your diagnosis? Multiple myeloma. Very good. Absolutely. Everyone, right? Multiple myeloma. So this is your MOT cell. Yeah, this is your MOT cell. Diagnosis is multiple myeloma. Diagnosis, multiple myeloma. Okay, let me give you a history. 35-year male, pancytopenia, DIC. This is the bone marrow examination. What is the next line of investigation? Fish flow cytometry again. 35-year male, hepatosplenomegaly, pancytopenia, DIC. Bone marrow aspirate shows such a thing. 25% cells are like this. What is the next line of investigation? Tell me. Fish or flow cytometry? Arey Baba, most of you are answering fish. Very good, very good. You are not answering flow cytometry. Why? Can anybody tell me? Morphology is equivocal or morphology is definitive here? Morphology is definitive. What am I seeing? They are blast, definitely. Large cells. Are they having abundant granular cytoplasm? Yes. In fact, they are having multiple or rods, isn't it? multiple or rod. Such a cell having multiple or rod. What is this called as? Faggot cell. Multiple or rod faggot cell. What will be your diagnosis? Suspicious of what? AML M3 or promyelocytic leukemia. It is a myeloid or APML we call it. APML. Promyelocytic leukemia. Very good. So what do I do? Very good. I have to do, first I have to do FISH in this. Cytogenetics I have to do. Can anybody tell me FISH for what should be done? FISH for translocation 821, translocation 1517, 922. Which FISH should you be doing? Which FISH you should be doing here? Yes, very good, very good. 1517 translocation we have to check, and that will be nothing but what? PML RARA translocation. PML RARA translocation. Very good. And what is the treatment? Treatment is retinoic acid. All trans retinoic acid is the treatment. Right? Just a minute. Yes, what is the treatment here? Sorry. All trans retinoic acid is the treatment, right? Correct. Let me write ATRA. Treatment is all trans retinoic acid. अरे सिंघम में ब्रेक नहीं लेता है कभी, ठीक है? नो ब्रेक्स. विल फिनिश ऑफ अनदर 15-20 में, आधा घंटे में खत्म कर लेते हैं, ठीक है? ओके, यस यस यस, लेट अस लुक. ओके, दिस पेशेंट इज हैविंग mental retardation. This is a bone marrow aspirate. Tell me now. Mental retardation, bone marrow aspirate. Mental retardation, bone marrow aspirate. What are you seeing here? Pancytopenia also has been given to us. Yes, these are your blebs that are seen. Membrane blebs. Membrane blebs on the blast. Yes, diagnosis AML M7 or megakaryoblast associated with Down syndrome. Associated with Down syndrome, right? Yeah. Some people are confusing this hairy cell. They are not. Hairy cell will be just like, okay, look at this difference. These are the blebs that I am talking, like this. Hairy cell will be like this. Okay, hairy cell will be like this. Okay, tell me now. Lytic lesion, 2-year-old child. Lytic lesion in the skull. What are you seeing? What is the diagnosis? This is a spotter. What is your diagnosis? On what is a marker also? Diagnosis LCH. What is LCH stand for? Langerhans cell histiocytosis. What are the markers? Markers will be S100, which is a non-specific marker, CD1A, which is more specific, CD207, most specific marker. Yes, very good. These are Burbeck granules. These are Burbeck granules. Most specific marker is CD207, also called Langerhans. CD207, also called Langerhans. Okay? Okay, now, so we come to this. This is a flow cytometry. How to interpret flow cytometry? Although I don't expect you to get this question, but unfortunately in AIIMS, they ask sometimes such questions. Okay, so flow cytometry mein, first look at the flow cytometry here. First I am giving a dotted graph. This is the dotted graph which is plotting on the x-axis. They can plot anything. You have to look for forward scatter and there is a side scatter. Okay, forward scatter, short form I will use FSC. Okay, this is your forward scatter, FSC, and side scatter is your SSC. Forward scatter, side scatter. Forward scatter tells me the size of the cell. Tells me the size of cell. So forward scatter, more the forward scatter, larger the cell, lesser the forward scatter, smaller the cell. And side scatter tells me the cytoplasm complexity. Basically, it tells me granules. Complexity of the cytoplasm, that is your granules. Meaning, if the cytoplasm is having more granules, more or rods, the side scatter will be more. And if it is having less granule, less or rod, the side scatter will be less. Okay. Forward scatter, side scatter. Yes. And they can ask even in NEET PG also. So, because we never know when examiner will ask those questions. Now, so look at this green group of cells here. Can you identify what is this green group of cells showing? Group number 1 I am labeling. Group number 1, look at this comment upon their scattering. The forward scattering is very high or very low? Low forward scattering. And also their side scatter is also low. Can anybody tell me? Forward scatter is low means the size of the cell is large or small? Tell me what is the size of the cell? Large or small? Yes, SSC is complexity of the cytoplasm. Okay, side scatter, complexity of the cytoplasm, basically granules of the cytoplasm. Forward scatter, size of the cell. Tell me now, group number 1, this is showing a low forward scatter. Size is large or small? Small. And iska side scatter is also what? Low. Means there are more granules or no granules? Almost no granule. Tell me now, which cells in your blood will be having very small in size and also they do not have granules? These are your group number 1 is your what? Lymphocyte. I hope all of you can understand. These are mature lymphocyte. Mature lymphocyte. I hope all of you can understand group number 1. Now, try to interpret this group number 2. Another group I am showing you, group number 2. Tell me now. Group number 2, look at their forward scatter as compared to your lymphocyte. The forward scatter is what? More as compared to the lymphocyte. If the forward scatter is more, that means these cells are larger than your lymphocyte, understandable, and their side scatter is also slightly more. Means what? Their complexity of the cytoplasm is also more. So what do that mean? Are they lymphocytes? No, they are not lymphocyte. So they are some other cell, right? So these are your monocyte actually. Sorry. So group number 2, these are the monocytes. Now look at the group number 3 here. Group number 3, what you are getting? So look at the group number 3, their side forward scatter almost same as monocyte. I hope all of you can see this. Forward scatter is almost same as monocyte, but their side scatter is higher than your one? Monocyte. Isn't it? Side scatter is higher than the monocyte. What are you thinking? Tell me now. So these cells are large cells or small cells? They are small only, not very large, but their side scatter is more. That means they have more of what? Granules. These are your neutrophils. So group 3 here are the neutrophils, or we can say they are what? Polymorphs. Any granulated, even eosinophil, basophil also will come. Okay, let me try to see how many of you can answer now. I am showing you group 4. A hypothetical group 4. Tell me now, what is this hypothetical group 4 and a hypothetical group 5 also? Tell me, sir, what are hypothetical group 4 and 5? Let us first focus group 4. Tell me, what is the forward scatter and side scatter of group 4? So if there are cells here, their forward scatter is high and side scatter is also high. Forward scatter is high, side scatter is high. And group 5, look at the group 5, the forward scatter is very high, but side scatter is very low. So tell me now, yes sir, what are these cells? First thing, because their forward scatter, both 4 and 5, forward scatter is high, means they are small or large? They are large. Mature, immature? Mature, immature? Very good, they are immature. I can say they are blast. Very good, very good. Let me see how many of you are interpreting it. Now tell me, both 4 and 5 are blast. One is a myeloid blast, another is a lymphoid blast. Tell me which is which blast. Now we can understand why, if morphology was not getting us diagnosis, we can use flow cytometry for subtyping. Tell me which is what? 4 myeloid blast, correct, and 5 lymphoblast. Very good. So 4 will be myeloblast and 5 will be lymphoblast, correct? 5 will be lymphoblast. I hope all of you are now understanding. Based on the scatter plotting, I can guess what is the cell. I am not guessing, sorry. I can interpret the scattering and I can tell you how complex is the cytoplasm and what is the approximate size of the cell. Isn't it? That is what I can predict from or tell from the flow cytometry. Now, in flow cytometry, what we can further do is we can do markers for individual cell. So let me say I take these cells and I will do markers, and the again it will give me a scatter. So for markers, look at this. What is 5? 5 forward scatter is high, means cells are small or large? Large. Large cells. Side scatter is low. Look at side scatter, low. Side scatter is low means they don't have granules. That's why I call them lymphoblast. Whereas in 4, forward scatter is high, means they are large cell, blast, correct. Side scatter is also very high. That means they are what? Having more granules. That is why I call them myeloblast. Isn't it? Yeah, if the forward scatter is very high, we will consider them blast. Okay, okay. Now look at this. This is your, okay, carefully observe. What is given to us here? TDT, and what is given to us here? CD10. So they have done marker for CD10 and TDT. In the same cell, there is a graph telling us CD10 and TDT expression of that cell. Okay, again look at this. These are the dots that are there. They are the cells, isn't it? And I hope all of you are able to see one line, vertical line here. Yes, this is one line I am talking. And there is another line like this, isn't it? Yes, I am seeing two lines here. Now look at this. Whatever is the marker on this axis, this line is the cutoff line. Anything beyond this will be considered. Beyond this line will be considered positive. Before this line will be considered negative. So can anybody tell me these group of cells, the group of cells that I have circled out, these group of cells, let us label them 6, group number 6 here. Tell me now, group number 6, comment upon their CD10 status. Group number 6, comment upon their CD10 status. Anybody? Group number 6, comment upon their CD10 status. I want only CD10 status. I told you beyond this line for this axis will be considered positive. That means these are CD10 positive. Yes, correct. So these are CD10 positive. Anybody remembers if they are CD10 positive, they could be a precursor cell or even one germinal, isn't it? Yeah, they are positive. Now look at this. What about this line? Again, for the y-axis, look at this. For the y-axis, we look for this line. This is the line. Above this will be positive. Below this will be negative. So above this we consider positive. Below this we consider negative. For whatever is the marker that is plotted here. What is the marker that is plotted here? TDT. So tell me the same group of cell, what about their TDT status? Same group of cell, what about their TDT status? Very good. They are CD10 positive and also they are TDT positive. So can you tell me they are what then? They are what? Yeah, these are immature cells. Immature cells. CD10 and TDT can be immature, both B and T cells, remember. Okay. Yes, very good, very good, very good. Now, look, another has been given. Please try to interpret now. Let me say group number 7 and group number 8 also I am writing. Two groups I am showing here because 7 and 8, two groups are there here. Tell me now. Tell me about, comment upon 7 now. Group number 7. What about them? What is the marker shown on this axis? CD34, which is also precursor marker. And on this axis, 79A. 79A is a B cell marker. Okay. 79A is a B cell marker. Tell me now, group number 7. What is group number 7? Group number 7. Group number 7, CD34 positive and CD79A also positive. I hope all of you can understand why. CD79A, this group is coming beyond this line, positive, and it is coming above this line, positive. So both are positive, isn't it? Yes. Tell me group number 8. Comment upon group number 8 here. I want to see how many of you comment it properly. Group number 8. Please comment upon group number 8. Then I will give you one more. Let me see how many of you can answer this also. Yes, sir. Tell me now. What is group number 8? Group number 8, look at this. It is beyond this line, means it is positive for CD79, but it is negative for CD34. Means they are mature or immature cells. Group number 8, what are they? Group number 8 are mature B cell, isn't it? Group number 8 are mature B cells. Just a minute. Yeah, correct. They are mature B cell. Mature B cell. I hope all of you understood. Now interpret. Now another I am giving you. Interpret group number 9, group number 10. Tell me what is your diagnosis in group number 9 and group number 10. Group number 9, group number 10. 10 is PNH. Very good. Very good. 10 is PNH. Why PNH? Because it is negative for 59 and also negative for 55. Because look at this. Below this line will be negative for this marker, negative for 55. And before this line, it will be negative for this marker, 50. So it is PNH. Very good. And what is 9? Normal. Because 55 and 59 are positive normally. Understood? Now, so I don't want to give n number of permutation combination. I can give any number of permutation and combination and ask you what is it. Yes, you should be knowing that. Okay. So somebody was answering in the chat box, hyper IgM syndrome. No, nothing is hyper IgM syndrome here. For hyper IgM syndrome, what marker will I use? CD40. Remember, because CD40 should be absent there, right? Yes. So 10 is PNH. 10 is PNH. 9 is normal. 7 and 8. Look at this. 7 is of course both positive, understandable, because this is above this line and also beyond this line. 8. Look at this 8 group of cell. They are positive for this marker. What is the marker here? 79A. They are positive for this marker. That means they are B cell. But they are negative for this because they are beneath this line for whatever is for the y-axis. What is the for y-axis? 34. They are negative for 34. That means they are not precursor, but they are still what? B cell. That means they will be what? Mature B cell. That means the cells that are there are mixture of both mature and immature B cell. Okay. Next, another gray matter consuming focus. Let us see bleeding disorder. So in bleeding, let us talk about what do we look for. We look for clinically petechiae, purpura and bleeding time. 3 things, and clotting time. 4 things. Petechiae, purpura, bleeding time, clotting time present. So increased BT, sorry. Petechiae, purpura present and increased BT, primary plug disorder. On the other hand, ecchymosis, hemarthrosis and increased CT. Ecchymosis, hemarthrosis, increased CT. Secondary plug disorder. Secondary plug disorder. How T cell is mature or immature? Based on CD34 TDT. TDT is present and 34 is present, immature, absence of them, mature. Okay. So in primary plug disorder, my next investigation will be platelet count. Immediate investigation, platelet count. Yes. So platelet count either decreased or normal. So tell me now, if the platelet count is decreased, thrombocytopenia we understand. So we look for immature platelet fraction. Immature platelet fraction is like a platelet reticulocyte count. So if the immature platelet fraction is increased or decreased, more than 6 or less than 6. So immature platelet fraction more than 6 and less than 6, sorry. So if it is more than 6, it is called megakaryocytic thrombocytopenia. If it is less than 6, it is called amegakaryocytic thrombocytopenia. So we have megakaryocytic and we have amegakaryocytic thrombocytopenia. Mega and amega. Mega and amegakaryocytic thrombocytopenia. Now, so what is megakaryocytic? Bone marrow is showing more megakaryocyte, that is called megakaryocytic. Bone marrow doesn't show megakaryocyte, that is amegakaryocytic. Now, if it is a megakaryocytic, bone marrow is showing more megakaryocyte. It is what you call counterpart will be hemolytic anemia in your RBCs. Hemolysis is happening, stimulus is there to the bone marrow, and that is why hyperproliferation was happening. Here we call it megakaryocytic. Megakaryocytic thrombocytopenia's clinical picture again. 4 important clinical findings you can get. 4 important: renal failure and diarrhea history is there. Patient is having reduced platelet count, immature platelet count is high, and renal failure and diarrhea. What are you suspecting? Anybody? Or there is a viral infection. What are you suspecting here? Or if it is in females or history of autoimmunity, what are you suspecting? Or CT is also increased. See, both BT and CT are increased. This is a complex disorder, both primary and secondary problem, isn't it? Yes. Tell me now. Sir, renal failure and diarrhea. Thrombocytopenia with renal failure, diarrhea. Join all the dots. Renal failure, diarrhea and thrombocytopenia. What are you thinking of? See, renal failure, diarrhea, thrombocytopenia. Only one diagnosis I can suspect, HUS-TTP. And that is why peripheral blood smear shows schistocytes. For sure, I am clear my diagnosis is what? HUS-TTP, isn't it? Yes. HUS. So, what is it? Or TTP. What is your diagnosis? HUS-TTP. Treatment. What is the treatment for this condition? Treatment will be plasmapheresis if it is a autoimmune mediated, because this can be a immune mediated. Do plasmapheresis or give steroids. If they don't respond, IVIG. If they don't respond, do splenectomy. This is in order we are doing. For autoimmune or immune mediated condition, first plasmapheresis, then steroids, then IVIG, then splenectomy. If it is a congenital deficiency of ADMTS13, we give FFP. Aspirin is given in either of the condition. So that is your TTP. Now, patient is having a thrombocytopenia and increase in immature platelet count and viral infection history is there. Patient had a respiratory tract or anything and a child also, acute ITP. We are suspecting acute ITP. Treatment of acute ITP, wait and watch. Treatment of acute ITP will be wait and watch, isn't it? Because it is a self-remitting. When FFP is given in TTP, if it is a congenital deficiency of ADMTS13, we give FFP. The first condition is for autoimmune mediated, antibody mediated condition. Okay. If it is a deficiency, we give FFP. Congenital deficiency, we give FFP. Next, females and autoimmune history is there. Then what? Females autoimmune history and also prolonged disease illness. Thrombocytopenia is for many weeks to months. Chronic ITP. Chronic ITP. Acute ITP usually onset few days. Chronic ITP many weeks will be there. Chronic ITP treatment again same, steroid, IVIG, splenectomy, because it is autoimmune mediated. Increased BT and increased CT also. Obviously, this is a disease which is having both primary and secondary plug, mostly DIC. Mostly DIC. Right? Next is we'll talk about the other side. Platelet count is normal. Then what? See, if platelet count is normal, but the patient's having petechiae purpura, bleeding time is increased, I suspect two things now. What is that? One, either the patient is having a functional disorder of the platelet function disorder, or petechiae purpura can be as a part of your small vessel vasculitis. Small vessel vasculitis also can lead to bleeding, petechiae purpura. You might think it is a thrombocytopenia. It is not thrombocytopenia because platelet count is normal here. So, if platelet count is normal, check if there is any associated history of glomerulonephritis or a pneumonitis. Glomerulonephritis, they will give hematuria. Pneumonitis, they will give hemoptysis. If it is there, yes or no. If it is yes, if there is associated glomerulonephritis or pneumonitis, answer yes or no. If no, platelet function disorder. If yes, small vessel vasculitis. Small vessel vasculitis. Now let us talk small vessel vasculitis and platelet function both. So for platelet function disorders, what do we do? Platelet aggregation test is the investigation. So platelet aggregation test, what aggregation we do? We do three important aggregation: ristocetin aggregation, ADP and collagen aggregation. If it is absent to ristocetin, tell me what is your diagnosis here? Absent aggregation to ristocetin or absent ristocetin aggregation, problem is adhesion disorder, that is your either von Willebrand disease or it is a Bernard-Soulier. If there is absent ADP and collagen aggregation, it is a Glanzmann thrombasthenia. Glanzmann thrombasthenia, or even aspirin intake, because that is your what? Aggregation disorder, isn't it? Yes. Now small vessel vasculitis. Let us talk small vessel vasculitis. Small vessel vasculitis, petechiae purpura, increased BT, normal platelet count, and there will be associated manifestation like hematuria or hemoptysis. Check for age. Age is important in vasculitis. age, small, especially in small vessel also, age, adult or a child. Can anybody tell me a child having small vessel vasculitis, petechiae purpura is there and also hematuria is there. Suspect only one. What is that? HSP, Henoch-Schönlein purpura. Yes, Henoch-Schönlein purpura, and that will be having what? Abdominal cramps. History of other history will be abdominal cramps will be there, and there can be arthritis history. Thank you. Thank you. I will drink water. Yeah. Okay. HSP. Now, what if it is an adult? Tell me now. In an adult, what are you thinking? If it is an adult, mostly check for serology now. Check for ANA and ANCA. They would have given you, or they would have given you a associated history with that condition. Tell me now. Patient is having a malar rash. What are you thinking? And or ANA positive. What are you thinking? Malar rash and or ANA positive. Adult having petechiae purpura. Yes. What are you thinking? Lupus. Very good. This is your lupus. Lupus is also small vessel vasculitis. Remember, right? Next, one more is patient is having P-ANCA positivity. P-ANCA positivity. Can anybody tell me what are you thinking? P-ANCA. Two conditions for P-ANCA. Tell me two conditions for P-ANCA. P-ANCA. Priyanka nahi P-ANCA. Yes. Two conditions for P-ANCA. Churg-Strauss and microscopic polyangiitis, isn't it? So I am looking for other associated history like asthma, eosinophilia or a cardiomyopathy. Tell me what is this condition? If P-ANCA positive and asthma, eosinophilia or cardiomyopathy is there, what are you thinking of? Yes, I am suspecting Churg-Strauss, isn't it? If they are not there, then I will consider MPAN as my diagnosis. MPAN, isn't it? Yes. On the last one, look at this one more I am looking for. There is saddle nose. Clinically, saddle nose, granulomas and C-ANCA positive. What are you thinking? This is your Wegener granulomatosis. Wegener, another name for Wegener is what? GPA. Yes, GPA, granulomatosis with polyangiitis. Granulomatosis with polyangiitis. Now, lupus has a double-edged. Remember, what about lupus? Let me tell you, in lupus can cause thrombocytopenia also. Lupus can come in chronic ITP also. Because it is an autoimmune disease, it can come in thrombocytopenia. Kawasaki is not a DD here. They will not present with petechiae purpura. Kawasaki is a medium vessel vasculitis. Correct. Okay. So this is done your bleeding disorder, primary plug disorder, another one more flow chart, and your whole hematology is done. And I'm sure from these 6 flow charts that you have written, you will end up getting at least 3 to 4 questions. That is assurance from my side. GPA is granulomatosis with polyangiitis, also known as Wegener. EGPA, eosinophilic granulomatosis with polyangiitis, right? Okay, sir. Secondary plug disorder. Thank you. On demand, I will drink water. Yes. Secondary plug disorders. In secondary, we look for PT, APTT. Two important tests. CT already is elevated. PT, APTT. Secondary will have hemarthrosis, hematoma, ecchymosis, clotting time elevated. Look for PT, APTT. 4 possibilities. Only PT increase. Anybody remembers? PT determines efficacy of which pathway? PT determines efficacy of which pathway? I am looking for the chat box, please. And APT determines which pathway? PT determines which? APTT determines which? MPAN, microscopic polyangiitis. Okay, only PT elevated, only APTT elevated, both normal, both elevated. Yes, very good. PT extrinsic, APTT intrinsic. Now, only PT elevated means a factor 7 deficiency. Isolated factor 7 deficiency doesn't happen clinically. It is associated with vitamin K deficiency. What are the vitamin K dependent factors? Anybody remembers vitamin K dependent factors? 2, 7, 9, 10. Vitamin K dependent factors are 2, 7, 9 and 10. Vitamin K dependent factors, isn't it? Now, sir, although 2, 7, 9, 10 are there, factor 7 has the shortest half-life. That is the reason why vitamin K deficiency, when it happens, First factor to deplete in the plasma, factor 7. That is why elevated PT initially. Later on both will get elevated. Right? Okay. Next, only APTT. Okay, what is the treatment for vitamin K deficiency? Vitamin K deficiency commonly found in newborn. Treatment, IV vitamin K 2 mg. This is not prophylaxis. This is a part of treatment. IV we are giving. Prophylaxis IM is given. And if not responding, FFP should be added. Next. Yes. Now, only APTT is increased. Only APTT is increased. Check for age. Age of the person. Age of the person, child or an adult. If it is child, we are suspecting inherited condition. Check for the sex. Boy or a girl. Why boy or a girl? Important because some of them are X-linked recessive which do not occur in boys, which do not occur in girls. Sorry. So, if it is a girl, then what? Von Willebrand disease or hemophilia C. Hemophilia A and Christmas disease, which are commoner than these two, but they are X-linked recessive. They do not occur in girl. So, if they have given you a girl child, do not make hemophilia and that is hemophilia A and Christmas disease. Hemophilia C is factor 11 deficiency. If it is a boy, anything can be there, but more likely will be hemophilia A or Christmas disease. So, we do mixing studies. If there is, so for factor deficiencies, we can be doing mixing studies. Mixing studies, we mix coagulation factor. Whichever factor is deficient, suspected to be deficient, we mix and check whether it is becoming normal or not. Okay, at your level, don't get into too much of mixing studies. Forget about it. We can do mixing studies here. Remember that. Now, so it could be either hemophilia A. That means if your APTT gets corrected after adding factor 8, that will be hemophilia A. Treatment of hemophilia A, recombinant factor 8 or cryoprecipitate. Alternative is cryo. Recombinant factor 8. Okay. Next. Or it could be a Christmas disease. Christmas disease is factor 9 deficiency. Treatment will be recombinant factor 9. Please change this misprint in your printed edition. Factor 8 has happened there. Treatment will be recombinant factor 9 or FFP. FFP is correctly given, but it is recombinant factor 9, not factor 8. Please correct this. Yes, vasculitis can increase. पुअर टोमेटो जब तुम्हें सीट मिलेगा ना तब दे देना, मैं पी लूंगा, ठीक है? अभी तक तो पानी काफी है मुझे. And don't forget when you get a seat. Don't forget me. Okay. Yes, sir. Next is hemophilia C. Hemophilia C, FFP is the treatment. Hemophilia C, FFP is the treatment. Factor 11 deficiency is hemophilia C. Okay. Yeah. If it is an adult, what we are suspecting in adult? Yes. What we are suspecting in an adult? In an adult, we are suspecting antibodies to factor. These are called factor inhibitors. So, APTT is increased in an adult, then check clinically two things. Patient is symptomatic, that is bleeding is happening or not happening, basically hemarthrosis, hematoma, etc. Or patient doesn't have bleeding and thrombosis is there. Tell me now, what are you thinking? Sir, patient is having bleeding, that is symptomatic means bleeding is there and APTT is prolonged. I am suspecting antibodies to factor 8 commonly. If there are antibodies to factor 8, again we do mixing studies and this will confirm these are factor inhibitors. Factor inhibitors are nothing but antibodies to factor 8. Von Willebrand factor, there are 3 types of von Willebrand diseases, by the way. The one which will have severe elevated APTT will be type 3 von Willebrand disease, we call it. Severe type of von Willebrand disease. Milder will have only adhesion problem. Severe will have coagulation problem also. Mixing studies, we mix either recombinant factor and check whether clot is formed, or we mix normal plasma and check whether clot is formed. Yeah, this is called also factor inhibitors are also called acquired hemophilia. Now, on the treatment will be steroids here, immunosuppressive, basically because of autoimmune condition. Now, if there is no bleeding and thrombosis, there are 2 DDs. Remember, patient has thrombosis but elevated APTT. Patient has thrombosis but elevated APTT. 2 DDs, factor 12 deficiency and APLA. So, it could be factor 12 deficiency or it could be APLA. How do I know APLA? For APLA, look for recurrent abortion. History of recurrent abortion, start thinking of APLA. If platelet is very high, consider thrombocytosis. Essential thrombocytosis is the suspicious condition. Okay. FFP versus cryoprecipitate. Okay, I'll come to that part. Okay. So if it is recurrent abortion, dilute Russell Viper venom test will be done. That is your APLA, antiphospholipid antibody syndrome. Cryoprecipitate contains only 4 factors. You will understand now. Cryoprecipitate contains fibrinogen, factor 8, von Willebrand factor and factor 13. That is why cryo can be used only in these conditions. FFP will contain all factors. So cryo is used only in these 4 conditions. हाँ, एप्ला के लिए ऑफ कोर्स जेंडर भी चेक करेंगे, फीमेल्स में होगा, रिकरेंट एबॉर्शन जैसे ही बोला तो फीमेल में होगा, but that doesn't distinguish factor 12 deficiency because factor 12 deficiency can happen even in females also. Okay. Next, both normal. Patient is having hemarthrosis, ecchymosis, everything, and both are normal. Only one disease, factor 13 deficiency. Treatment will be recombinant factor 13 or cryoprecipitate. We can be giving cryo, right? Now, both increased. What are you suspecting? If both are increased, then check thrombin time. Thrombin time of the patient is also increased or thrombin time is normal. If thrombin time is normal, only one, factor 10 deficiency. Thrombin time normal, factor 10 deficiency. Thrombin time also increased. Then check for platelet count and D dimers. Platelet count and D dimers, yes, platelet count and D dimers normal or platelet count normal, D dimer normal, or low platelet and high D dimer. Low platelet, high D dimer, DIC, normal, it will be afibrinogenemia. Treatment of afibrinogenemia, cryoprecipitate. Treatment of DIC will be, yes, start with FFP and platelets, and if not start with platelets and FFP. If not responding, add heparin to the treatment. If not responding. Okay, we'll do one thing. We'll take a very small break. 5 minutes break. I start back in 5 minutes. Okay. Break ले रहा हूँ. Hi guys. Welcome back everyone. Yeah. On the lighter side, now I know why you were telling me to take drink water and drink beer also, so that आपको diuresis, मुझे diuresis होता तो आपको break मिल जाता, right? On the lighter side. Okay, let us come back. Umbilical cord stump bleeding, factor 13 deficiency can cause. Vitamin K deficiency, very rarely Glanzmann thrombectomy also can cause. Okay guys, chalo. Next one. Okay, so what is this? Investigation. Pakka question expect karo isse, because last 4-5 exams, 5 questions. Every exam except for this INICT, all exams questions have come. Simple, I will discuss both simple and advanced both. What is this graph? This graph is your TEG. What is TEG stand for? Thromboelastography, right? TEG, thromboelastograph. Now in TEG, few things, forget about this R value. You should know what is R value. R value is this single line that is there. This is your R value. R value tells coagulation, tells you the coagulation factor. Basically, R value is telling you the time taken for initiation of fibrin formation. Clot formation को initiate करने में कितना time लग रहा है? That is what it is measuring your coagulation factor, R value. Next, after R value, look, there is, the clot has reached at this point. This is the 20 mm clot. So once the line has split like this, that means clot formation has begun, and here it is now 20 millimeter clot, and whatever time it has taken from beginning, initiation of clot formation to 20 millimeter clot, that is called K value. K value measures your fibrinogen. K value measures fibrinogen. So that means basically what is the rate of conversion of fibrinogen to fibrin is measured by K value. Coagulation, all other coagulation factors are measured by R value. Then leave alpha angle, an angle will be created. MA, what is MA? Maximum amplitude. This is nothing but maximum thickness of the clot. This is decided by both platelets and even coagulation factors. Obviously, you require what? Platelets and coagulation factor. That is your maximum amplitude. So, if you don't have coagulation factors, then your thickness of the clot will be less. If you don't have platelets also, the thickness will be less, by the way, right? That is what is MA. And then, after this, look at this, the thickness of the clot is reducing after this, and it is, that means fibrinolysis has begun. Fibrinolysis has begun, and this is called LY30. After 30 minutes of achieving MA, we measure the thickness. Thickness will be less after 30 minutes. That means there is a fibrinolysis. This is called LY30. LY30 is lysis after 30 minutes. So TEG measures primary plug, secondary plug, and also fibrinolysis. All three is measured by TEG. Audio is not there. No, audio is there. Audio is there, please. Near maximum thickness of the clot, and it will be measuring platelet and coagulation. Okay, it is measuring platelet and coagulation. So based on this, we end up interpreting. Let us talk about interpretation of the TEG now. Okay, yeah, let us interpret the TEGs. Let me give you important interpretation. Okay, look at this. This is your TEGs I am showing. The first one is normal. Okay, let us say first one is normal. So this is your comparison. You should be knowing this is, what is this now, by the way? Tell me. Let me just try to appreciate few things here. What is this? This will be your what? R value. And what will this be, by the way? MA is there here, isn't it? Yeah. Now, so let us look at this second one. Can you identify in this graph? Second one. Can you tell me what has happened to this? What is this? This is increased. What is increased? R has increased. Can you suggest what has happened? In this, R is increased, isn't it? R is increased. In indication for TG, any coagulation or bleeding disorder, we can do TG. R is increased and your MA is decreased also here. Can anybody tell me now what are you suspecting in this? R is increased and your MA is reduced. Meaning what? Thickness of the clot is more or less here? Thickness of the clot is less, but R is more. Meaning what? R is more, definitely coagulation factor deficiency. And can coagulation factor deficiency lead to decreased thickness of the clot? Yes. See, if only MA was reduced without R increasing, then I would have thought of thrombocytopenia or any platelet disorder. Here, R is also increased, MA is reduced. I am thinking of a coagulation factor deficiency. Right? So, anticoagulant. Some anticoagulant or heparin, effect of heparin, warfarin, or maybe coagulation factor deficiency, all your hemophilias, Christmas disease, everything. Remember, it cannot distinguish between these individual diseases. It can just be a screening test. This is a screening test. Next, can you tell me what is this now? This is, in this R is normal. R is normal, although it appears from normal, it appears slightly more, but it is within the normal range only. Tell me what has happened here. MA has reduced. MA is decreased. Can you tell me what could be the possible problem here? R is normal, MA is reduced. Is it a coagulation disorder? No, it is not a coagulation disorder. What is this then? Yes. MA is less, R is normal. What are you thinking? Probably it is having problem with the platelet. Either you have drugs which have induced the platelet blockers like aspirin can cause this, or patient is having thrombocytopenia. Okay, so platelet disorder, or even your both Glanzmann and what do you call Glanzmann thrombocythemia Bernard-Solier also can cause this. Okay, problem with the platelet here, isn't it? Can you tell me what is happening in this? In this also R is normal. Okay, what has happened here? Your clot is getting lysis very fast. Are you seeing? LY30 will be what? See, normal clot thickness was remaining normal up till here. The thickness already has become almost what? 0 here. Meaning what? LY30 is increased. LY30 is increased. Alpha angle is the angle that is created, that will be inversely proportional to the K value basically. Alpha angle measures rate of fibrin cross linking. That is the only question they can ask you. Alpha angle measures rate of fibrin cross linking. Okay. Yes, LY30 increased, you are suspecting fibrinolysis. Patient might be taking urokinase, streptokinase or a plasminogen activator, isn't it? Yes. Next, what is this? Can anybody tell me? R in fact is very less here. R is very less and your MA is increased. MA is increased. What are you thinking? MA is increased and is there lysis or no lysis? No lysis. So LY30 is normal. MA is increased. This is a thrombotic disorder. Hypercoagulation. Hypercoagulation. K indicates rate of fibrinogen to fibrin conversion. Rate at which fibrinogen to fibrin is converted, that is by K. So this is your hypercoagulation. Why hypercoagulation? MA is increased and it is not getting reduced at all. That means, is there a fibrinolysis or no lysis happening? No lysis happening, isn't it? Yes. Can you identify the next one? Look at this phase. What is this now? R is less or almost normal only. You can say this is a normal variation. MA has increased. So is it also a thrombotic condition? Until here it looks thrombotic, but still look at here, there is lysis happening. This was a pure thrombotic condition. Here lysis is happening, but it is a late lysis happening. Anybody, what is this then? Yes, very good. This is a DIC. But important in DIC, what is the DIC problem? Thrombotic disorder or bleeding disorder DIC? There is initial phase is thrombosis, that is called phase 1 or stage 1 of DIC. Later on, this leads to consumptive coagulopathy and that is leading to bleeding disorder. So, this will be DIC phase 1. This will be DIC phase 1 or stage 1. Hypercoagulable phase of your DIC. Hypercoagulable phase of your DIC. On the other hand, try to identify this, the last one. Now, what are you seeing here? Look at this. Your R is very, very high and your MA is very, very low. What are you thinking? This will be your DIC phase 2 or stage 2, which is hypocoagulation phase of DIC. Hypocoagulation phase of DIC. Okay. So until now, what all have come in exam? What is MA? What is TEG has been asked? What is this graph has been asked? What is MA has been asked? What is R value has been asked? What is LY30? Expect this. What is alpha angle? I told you alpha angle measures the rate of fibrin cross linking and individual images they can be giving of TEG. Hypercoagulation, simple. Look at this. MA has increased. There is no chance, no lysis happening at all. That's our hypercoagulation. Yes, in NEET. Previously asked in NEET only. See, whatever I am discussing, everything is important for NEET and INICT both. Yes, sir. Now next, we are talking vacutainers. For vacutainer, there is a proper order that we should be following. So what is the order that we should be following for vacutainer? Okay, look at this now. Everything is written to you. Just focus on this. Remember, first thing you should be taking will be culture bottle. If at all there is something for culture you have to take culture. In culture also, which will you take first? First you will take for aerobic followed by anaerobic. So aerobic, then anaerobic culture bottles, 2 bottles. Okay, if you are taking 2 of them. Then after that, citrate. Citrate is in blue color vacutainer. Citrate, blue color vacutainer. Now, so citrate is used for coagulation profile. For coagulation profile, the ratio of citrate to blood should be 1:9. For ESR also we use citrate. Citrate to blood ratio should be 1:4. So in your internship, you would have made this mistake for sure, that you have sent for coagulation profile and the lab rejects, saying that the sample is not properly sent because your ratio was not normal. See, in a citrate, there will be 2 markings that will be there. One is 1:9 ratio, another is 1:4 ratio. If you are not sending it up to 1:9, the sample gets rejected. So this confusion was there amongst doctors. That is why now we have done away with what? So for citrate, blue color, we use it only for coagulation. Now we have for ESR citrate is a different vacutainer, black color. So remember, they can expect this also in question. ESR, now currently we have new black color. So what we have done in ESR is we have made the tube thinner, so it becomes into same ratio. Okay. Next, after that, after citrate, you take the serum tubes. Serum tubes will be either red, which is only having powdered glass, or it will be powdered glass with polymer gel. If you are taking plain tube also, you can take, right? So this is the serum tube. So first will be culture, citrate, then serum tube. Serum tubes, serology, indirect Coombs test, immunology, etc. We use serum. Then after serum, you have to take heparin, which will be green, used in arterial blood gas analysis. Anywhere else we discussed? Any other investigation we use heparin? Yes, any other? OFT, osmotic fragility test also. Then after that, take EDTA. EDTA, lavender color or purple for CBC, blood grouping, RH typing, flow cytometry, etc. Then we use a yellow. Don't confuse this yellow with golden yellow. Golden yellow is a serum tube. This is a ACD tube. ACD tube for paternity testing, HLA typing and DNA studies. Then oxalate with fluoride. Oxalate with fluoride. Oxalate is the anticoagulant here, remember, and fluoride is a glycolysis inhibitor. Glycolysis inhibitor used for blood glucose. Okay, now, so yes, somebody is asking why you want to follow this order. Logical, culture has to be taken first. Why? Because you don't want to contaminate, isn't it? That is understandable. Now, why the other ones to be order? Okay, correct, you are right. Always remember, when we started, we had citrate and EDTA, two important things. EDTA, mechanism of action of citrate is a calcium chelator. EDTA is also calcium chelator. But EDTA irreversibly chelates the calcium. Means your blood will never clot if you add EDTA. And if you are taking for coagulation profile like PTA, PDT, then if EDTA, by chance, say suppose I take first EDTA, then what? I am taking the blood in the syringe and then what? I am injecting it into EDTA. Can there be some EDTA attached to this syringe now? Yes. And after that, if I put it into citrate, my blood, although it is in citrate, but it gets contaminated by EDTA. Because it has got contaminated by EDTA, I told you EDTA irreversibly chelates calcium. Because it irreversibly chelates calcium, if you remember in PTA, PDT, we ultimately have to induce clot formation in this plasma, isn't it? So if irreversible chelation, and for that, we were to induce clot formation, we were adding calcium in PTA, PDT. Isn't it? Because citrate is a reversible chelation happens by citrate, whereas EDTA irreversible. That is why we don't want things to get what? Mixed, and that is the reason why we end up having this order. And logic of serum having before EDTA is, for serum, blood has to clot. For serum, your blood has to clot. If you are adding EDTA and if it mixes, then you will never have a serum because there is no clot formation at all. And the logic of fluoride or the gray tube to be taken last, this is old historical. What is that? Before advent of fluoride, we were using only what? Oxalate. And for blood glucose, if you draw the blood first, the more time it will spend outside the body, more consumption of glucose by the RBC. Thus, blood glucose level would have been dropping down. And that is why blood glucose was the last sample to be drawn earlier. We still follow that. That's it. Although we are adding fluoride now. If you take it earlier, little bit earlier, no problem. But yes, we still take it at the last. Okay. Yes, sir. Okay. So this is one cross matching. I have given you this is the this one given to us. Not important. What is important? I will tell you. What sample do you take in cross matching? Remember, it is the patient's serum that you will be taking and the donor's RBC. Question mark will be which vacutainer? Tell me now. For cross matching of the patient, which vacutainer will you take? For blood grouping, we have to take EDTA, lavender. For cross matching, serum tube, either red or yellow tube. Mix it and then incubate it for 1 hour and then, yes, then add Coombs serum. So 3 things are added. Coombs serum, and then after that check for clumping. If clumping happens, then it is not cross matched. If the clumping doesn't happen, it is compatible. So not compatible if clumping happens. If there is no clumping, it is compatible. Okay. Yes. So this is your next. Okay. So look at this image now. This image is a blood warmer. What is a blood warmer? Basically, it is an instrument which will warm the blood to desired temperature. We can set the temperature here and it will deliver. The use of blood warmer is it prevents hypothermia. hypothermia is an important complication in which condition? Especially in massive blood transfusion. So we use it in massive blood transfusion. Okay. So both of them are different companies. That's why I have shown both of them, because examiner can give any company. Okay. So ultimately, how do I identify they are blood warmers? Temperature will be there, and they will be showing you something like this, where the blood tube will be passing through this, right? Your IV tube will be passing through this. We use it in massive blood transfusion. Yes, somebody was asking. Hemat is ended now. So we are now starting next systemic. Oxalate to prevent. Yes, oxalate is an anticoagulant to prevent clot formation. This question came, by the way, wrongly answered by many faculties also. I have seen that wrongly answered by many faculties on YouTube. So what was the question? This year INICT this question came. What is the anticoagulant used for blood glucose estimation? This question came. Two options were given. Oxalate was there and fluoride was also given. What will be the answer? Tell me. Oxalate and fluoride. What will be the answer? What will be the answer? No, break is over. We took break just before this, right? So I will not take break now. We'll finish it off. Another half an hour, we'll finish systemic. Systemic is easy. अरे अभी भी तो ब्रेक लिया, अभी नहीं लेंगे ब्रेक. No, not fluoride. That's what anticoagulant is. Oxalate. Fluoride is a glycolysis inhibitor. Okay, anticoagulant used was what? Oxalate, not fluoride. Okay, yeah. So usually we use potassium oxalate, but yes, oxalate. No. For blood glucose, okay, very rare. Okay, blue was given, then citrate will be used. Remember, this confusion, let me clarify it. Earlier, what was happening was we used only oxalate. Now, because of fluoride, you can take even in what? Blue Vacutainer also. So you can take in blue Vacutainer as well, but it should be fluoride, which will be the glycolysis inhibitor. So if they had given blue, then citrate will be the answer. If they had given gray, then oxalate will be the answer. Anticoagulant, if they had asked. If they had asked you glycolysis inhibitor, see, ultimately for blood glucose, you should have a glycolysis inhibitor added. It can be in blue, mostly it will be in gray, but can be rarely even in blue also. Earlier people used to take in blue, not now. We take in gray now. Okay, so let us talk about now. Okay, so I will be giving keywords and images are given. Okay, keyword: patient died of basal ganglia hemorrhage, left ventricular hypertrophy on autopsy. This is the biopsy finding. First this one, and then there is second one. Okay, try to identify. What are you seeing? Look, this is a blood vessel. I can see blood vessel. Why? Because there are cells, RBCs are there inside. These are the endothelial. And look at the thickness of the blood vessel has increased. And is there muscle here or it is just pink material? Pink material. ऐसा pink material मिलेगा तो क्या सोचेंगे? दो चीजें सोच सकते हो. One, amyloid. Another could be hyaline arteriosclerosis. With a history of hypertension, I will make a diagnosis of what? Hyaline arteriosclerosis. Yeah. Only thing is, with this history, no, it is not hyaline, but anyway, benign hypertension. Some vessels will still show benign benign hypertension or hyaline arteriosclerosis, isn't it? Yeah, if it was given light blue, citrate will be the answer in that case. If it was given light blue, then citrate will be the answer. Anticoagulant, if specifically word anticoagulant was asked, then it will be citrate. If that asked what else will be there, then answer glycolysis inhibitor is fluoride, sodium fluoride. Okay, next look at this. The second one, this is your onion skin appearance. What is this onion skin appearance? Where do you see? Malignant hypertension. So this is your malignant hypertension. Hyperplastic arteriosclerosis. Because of this, there will also be fibrinoid necrosis happening, which will lead to bleeding, in the kidney, and punctate hemorrhages will happen on the surface of the kidney. Okay. So benign, and this is a benign hypertension, and this is a malignant hypertension, right? Yes. Now, okay. So look at this. This is a gross examination. We can see what is the organ here? Kidney. Yes. Gross examination. History. Patient died of basal ganglia hemorrhage, LVH on autopsy. Same history. Previous question ka history hai. Okay, look at this. What are you seeing? On the, this is a gross examination. On the surface of the kidney, are you seeing these all small red dots that you are seeing here? These are separated here, and these are more into, fusing into each other here. So these red dots that you are seeing on the surface, they are nothing but bleeding that is happening. Why is bleeding happening? I told you, in a malignant hypertension, there will be a fibrinoid necrosis of the vessel happening, especially arterioles ka fibrinoid necrosis. When it happens, the arterioles start bleeding. And when arterioles bleed, that is what you are seeing, multiple small pinpoint hemorrhages that are seen on the surface of the kidney. This is called as what? Yes, sir. Correct. This is called flea-bitten kidney. This is called as flea-bitten kidney. Causes of flea-bitten kidney. See, flea-bitten is not specifically only for malignant hypertension. It is just tells me there is a bleeding happening from small vessels in the kidney. So it can be due to malignant hypertension. It can be due to infective endocarditis. It can be due to PAN. It can be due to RP gene. All RP genes can cause. It can be due to leptospirosis. It can be due to lupus. It can even be due to PSGN also, because there can be bleeding happening there. Although PSGN very rarely causes, but can be there. Causes of flea-bitten kidney. See, flea-bitten kidney is nothing but bleeding happening from the kidney. Small vessels say bleeding hona chahiye. That's it. Okay. Next is, okay, let me see this. What is the history given to us? 35-year-old diplopia and vessel biopsy, also tortuous temporal artery is given. And this is a biopsy from the vessel. Tell me, yes, what is your diagnosis? Yes, PSGN also can cause flea-bitten kidney, rarely, not common. That's why I have not written that. Yeah, 35-year-old diplopia, tortuous temporal artery biopsy has been given to us. What is the diagnosis? Yes, sir, what is the diagnosis? Yes, what is the diagnosis? Giant cell arthritis. Everybody, giant cell arthritis. Somebody, I like somebody now. Takayasu arthritis. Okay, there are few people, giant cell, few people, Takayasu. What is it? Tell me, giant cell or Takayasu? The differentiating feature between giant cell and Takayasu arthritis. Biopsy remains same, giant cells will be seen, fibrosis will be seen, and chronic inflammation in both of them. Now, the difference between giant cell and Takayasu, age. More than 50 year, make a diagnosis of giant cell. Here it is less than 50. 35 year diagnosis Takayasu, irrespective of which vessel is involved. Yes, देखो, simple question में फंस गए सब लोग. इसीलिए बोलता हूं, keywords को पहचानो. Always, how to look for keywords? Look for option first. Don't answer to me without me giving you options. Okay? Yes, not only to me, to anyone. Okay, let me give you clinical hints for this. Patient is having hepatitis B, hypertension, vessel biopsy. Option PAN, MPAN, giant cell arthritis. Yes, sir. And Kawasaki, one more. Yes. Can you tell me what is it? Keyword. What is the keyword here? Identify the keyword. Okay, vessel biopsy. Forget about vessel biopsy. Keyword. Option given are what? PAN is given, MPAN is given, and then what else has been given to me? Giant cell and one more, whatever I had. Kawasaki. Hepatitis B. Associated with hepatitis B. Which one out of them? Very commonly associated. Will be what? PAN. Patient is having hypertension because renovascular hypertension. Kidneys, renal vessels are commonly involved in PAN. That's why renovascular hypertension. And vessel biopsy, what is it showing? Fibrinoid necrosis. Look at this. This is a fibrinoid necrosis. Now we can understand why PAN will also cause flea-bitten kidney, because there is a necrosis happening of the vessel. If it happens in the kidney, there will be not glomeruli, but it in the renal vessel, it will be leading to bleeding there. Right? Yeah. Yes, correct. So that is what is happening. PAN. Okay. This is the lung image, gross examination of the lung. Patient is, let me say, having having hematuria and also hemoptysis. 45-year hematuria, hemoptysis. What are you thinking now? And this is the clinical image. What is this clinical image? Anybody, what are you seeing? There is a depression in the nose. What is this called as? Saddle nose. Very good. Saddle nose, and this is your fibrocavitary lesion in the lung, seen in Wegener's granulomatosis. Very important. Fibrocavitary lesions in the lung. Biopsy will show granulomas in the lung. Remember, don't make diagnosis of tuberculosis here. Saddle nose and hematuria, hemoptysis. Wegener's granulomatosis, correct? Or a GPA. What is GPA? Granulomatosis with polyangiitis, right? Yes. What ANCA positive? C ANCA positive. Already we discussed that, isn't it? Okay. This is your gross examination of heart. 2 questions. Identify the stain used and tell me what is the red and black arrow pointing. Identify the infarct in the image, which is infarct, which is normal, and what is the stain used here. What is the stain used here? Okay. The stain is triphenyl tetrazolium chloride, TTC. Very good. That is the triphenyl tetrazolium chloride. Grossly we used to identify the infarct on autopsy. Now look, the red color, brick red or red, is a normal myocardium. Now, actually TTC goes and binds to the LDH in the cell. Normal cells will be having LDH in the myocardium. They have LDH. The infarcted cell, when the cell is dead, the cell membrane damage, that's why LDH is lost from the cell. Because LDH is lost from the cell, I told you TTC binds to the LDH. There is no LDH in the cell because of the cell membrane damage. That is why it doesn't stain. The unstained areas, these are your infarct and this is your viable myocardium. Yes, correct. Okay, sir. Let us see. This is a biopsy. Myocardial biopsy. Question, keyword. Patient has a reduced cardiac output. This is a myocardial biopsy. Question asked. Multiple I am asking. What is the appearance called? What is the diagnosis? What is the etiology? And which failure in the heart? Because there is a reduced cardiac output. That means which failure? Systolic failure or a diastolic failure? What are you seeing here? What are you seeing here? What are you seeing here? Very good. Please write down. Not labeled in your image, I guess. Ninja star nuclei. What are ninja star? Look at the nuclei. They are having what? Star-like appearance here. Ninja star nuclei. Ninja star. These are the various, okay, ninja star nuclei. Where do you see them? Very good. DCMP, dilated cardiomyopathy. Please write it. Dilated cardiomyopathy. Anyway, I will give you a PDF. Don't worry. Even if you don't write it, don't worry about it. Etiology, mostly idiopathic, but genetic causes titin mutation. Genetic causes titin. Then drugs can be causing like alcohol, cobalt can cause. Then drugs like cocaine can cause, alcohol, cobalt, not cocaine, sorry, heroin. Then alcohol, cobalt can be causing. Cobalt is commonly seen in beer. Beer cardiomyopathy also it is called. Thank you. I don't want that. Hemochromatosis and failure, systolic failure. Okay. Okay, another question. This is also myocardial biopsy. Reduced cardiac output, myocardial biopsy. Again, same question. Appearance, diagnosis, etiology, which failure is happening? Yes, sir. Hint you want? Okay, let me give you a hint. Railway की डब्बी. Okay, but in English, what do they call? अंग्रेज क्या बोलते हैं? वो पता करना जरूरी है यहाँ पे, right? Yes, हम तो इसको डिब्बे बोलेंगे ना. बोगी भी बोलते हैं. Yes, this is called box car. Box car. Look at the nuclei. How are they appearing? Yes, how are they appearing? They are appearing. Look at this nucleus. This nucleus is appearing like a box car, right? So, you know, basically car is anything that will travel, that is called car, by the way. And railway के ना पटरी डब्बे दो होते हैं. One is, you know, which is not having any covering, no box. And another is having what? Box. This is a box car. So, this is a nucleus. Look at this. You are having appearance of a box car, isn't it? Even this one also, partly box car. So, box car nuclei. Where do you see box car? Very good. HOCM. HOCM. And what will be the mutation? MYH mutation. Sorry. MYH, not MYC. MYH mutation. Myosin heavy chain 7. MYH7 mutation. And failure, diastolic failure. Diastolic failure. Okay. History. Patient is having mitral stenosis. This is a myocardial biopsy again. Mitral stenosis. Myocardial biopsy. Tell me, what are you thinking? Muscle. I can see the muscle. What is this? This is an inflammatory lesion I can see. Inflammatory lesion having cells with abundant cytoplasm. These are all macrophages, or yes, they are macrophages and modified macrophages called as what? Yes, this is a Eschoff nodule. The whole nodule is called Eschoff nodule, which is very pathognomonic. And Eschoff nodule, yes, is pathognomonic. And what is it made up of? Eschhoff nodule is containing what? Eschhoff nodule consists of Anischkow cell. Anischkow cells are most pathognomonic cells. Most pathognomonic body will be Eschhoff nodule or Eschhoff body. Anischkow cell, lymphocyte, plasma cell also. Then giant cell. Giant cells are called as Eschhoff cells. So remember, Eschhoff cell is not a pathognomonic of rheumatic. What is pathognomonic? Either Eschhoff nodule is pathognomonic or Eschhoff body or Anischkow cell. या तो Eschhoff nodule या Eschhoff body दे या तो Anischkow cell दे, not Eschhoff cell. Apart from that, fibrin or necrosis also can be seen. History. Newborn respiratory distress. Tell me now, what are you thinking? Newborn respiratory distress. This is the alveolus. I hope all of you are able to identify. These are your AL I am writing, alveoli. And in the alveoli, there is a lining. This is your necrotic cell which is forming pink hyaline membrane. This is called hyaline membrane. So these are your hyaline membrane that are seen. Already labeled, don't worry. Hyaline membrane. What is the diagnosis? न्यूबॉर्न अगर बोलूंगा तो ARDS नहीं बोलेंगे, राइट? न्यूबॉर्न है तो HMD होगा. अगर इन एनी अदर एज आई कैन मेक अ डायग्नोसिस ऑफ ARDS बिकॉज हाइलिन मेम्ब्रेन कैन बी सीन इवन इन ARDS ऑल्सो. सो हाइलिन मेम्ब्रेन. व्हाट इज द रिस्क फैक्टर? बताओ, व्हाट इज द रिस्क फैक्टर फॉर HMD? रिस्क फैक्टर फॉर HMD मैटरनल हाइपरटेंशन या मैटरनल डायबिटीज? मैटरनल डायबिटीज मेलाइटिस, प्रीमेच्योरिटी. मोर इंपॉर्टेंट इज प्रीमेच्योरिटी, बाय द वे. Prematurity. Of course, COVID patient, same thing will be there because ARDS. In fact, prematurity will be the first one. Okay, I have written maternal, but prematurity. Okay, let us see this. Smoker or chronic hepatitis from childhood. Patient is not smoker from childhood, smoker or chronic hepatitis from childhood. This is the gross examination of lung. Now, patient has presented to you with sudden breathlessness and died in emergency. What? Diagnosis, complication. Both I am asking. Tell me, what is the diagnosis and what is the, even C-section also for HMD, correct? Yes, sir. Diagnosis, very good. This is your emphysema. These are your bullae that you are seeing, emphysematous bullae, right? These are emphysematous bullae. Thinned out dilated air spaces. Yes, sir. Tell me now, what is your, okay. If it is a smoker, it will be a centriacinar. If it is chronic hepatitis from childhood, alpha-1 antitrypsin. Alpha-1 antitrypsin deficiency can lead to hepatitis and cirrhosis, isn't it? And what complication I said? Yes, pneumothorax. Next. Let us look. History, smoker. Cough and sputum for last 2 years. This is a biopsy from the lung. Tell me now, what are you seeing? This is your cartilage. सब तो cartilage पता चलेगा. इस तरफ alveoli है, ये cartilage. This is your cartilage and this is your respiratory epithelium. Then you are having submucosa. Submucosal glands are there. The gland thickness has increased. What is your diagnosis? Chronic bronchitis. Correct? Chronic bronchitis. Anybody remembers what index do we do here? Index is your what? Menzer index? No. This is your what? Reed index. Correct. Reed index. Okay. Let me see history. Let us just history. History, sputum examination, 12-year-old having wheeze, episodic breathlessness and wheeze also. I'll give you wheezing as well. Sputum examination in a 12-year-old boy, episodic breathlessness and wheezing. What is this first image? What are you seeing here? Spirals. कौन से spiral है ये? Kirschmann spirals. Yes, correct. This is asthma. Very good. Asthma. Kirschmann spirals. These are extruded mucus which will be basophilic spiral-like structures. Kirschmann spiral. Second one. What is this now? Can anybody tell me? These are crystals. What crystals? Okay, these nucleated cells are eosinophils, but these are crystals. What crystals they are? Yes, sir. They are Charcot-Leyden crystals. Charcot-Leyden crystal made up of eosinophilic proteins, isn't it? And what is this body here? The third one, this is a sloughed off ciliated epithelium. Respiratory epithelium has been sloughed off and that forms a cellular body like this called creola bodies. All of them are seen in, yes, all of them are seen in asthma. Okay, history. Post pneumonia. Patient is having a repeated pneumonia and this is the history. Or I can give you one more. Child cystic fibrosis. This is a lung. Tell me what are you seeing? Cystic fibrosis child. This is the lung post-mortem. Yeah, what are you seeing here? Look, the bronchi are very thick walled. Fibrosis has happened and also they are dilated. These are not alveoli. Alveolar dilatation will be more peripheral. This is what? More central. This is your bronchiectasis. Bronchiectasis. Very good, very good, very good, all of you. Bronchiectasis. Okay, let us see. Yes, just don't answer. Just image. No. Ask me question and options also. Okay. Breathlessness, 10 centimeter fibrotic patch in the lung. Options. And this is a lung biopsy. Option, anthracosis, simple cold-worker pneumoconiosis, complicated cold-worker pneumoconiosis. Yes, sir. What is it? Anthracosis, simple CWP, complicated CWP. Three options I have given. Anthracosis, simple, complicated. Okay, what is biopsy showing? Of course, these are all what? Black color pigment that you are seeing. This is your, yes sir, carbon laden pigment. Okay, in the macrophages. Of course, will be seen in, see, these three are spectrum of the disease. Anthracosis is asymptomatic, no fibrosis. In fact, most of us who are staying in polluted cities, not me, but when I come to Delhi, I am in polluted city, by the way. Okay, so if you are exposed to pollution, you will end up having some amount of carbon-laden macrophages, that is called dust cell, that is your anthracosis. What is simple CWP? This will progress to fibrosis. The fibrotic nodules will be small, very small, usually around 2 centimeter in size, around 2 to few centimeters, we can say. Mild symptoms or no symptoms. That is a simple CWP. Complicated CWP, the fibrosis becomes extremely large, called as a progressive massive fibrosis. More than 10 centimeter, more than or equal to 10 centimeter fibrotic patch in the lung. That is your complicated CWP. My answer to question, complicated CWP. CWP, we can write complicated CWP. Yes. No, this is not ferruginous. Very good. So size matters here. Simple and complicated, that's what I told you, size. If somebody tells me 2 centimeter fibrotic patch, I will call it 2, 4, few centimeter. I will call it simple. Yes, sir. Tell me now, history. Let me give you a history. Breathlessness, fibrotic patch in the lung, manufacturer's roof sheet. That is the occupational history. Yes. Is it a cold worker pneumoconiosis? Yes. No, this is not. What is this? This is your asbestos body. What is asbestos body? Look at this. This is a golden brown body made up of within the macrophage, and it is made up of what all? Asbestos will be there. It will also contain iron. It will contain calcium and protein. It is made up of all these. Asbestos body. Yes, diagnosis, asbestosis. Which malignancy? Which malignancy? Most specific, mesothelioma. Most common, lung adenocarcinoma. Okay, let us see this now. Let us look at this. Let us look at this. History. 35-year female, hypercalcemia, weight loss, lung lesions. Is it a malignancy? Weight loss. Whenever weight loss is given, start suspecting either chronic inflammation or a malignancies, right? Okay, what are you seeing in this image? Look at this. There's a giant cell, I can definitely see. Options, okay, lung carcinoma, squamous cell carcinoma of lung, sarcoidosis, tuberculosis, and Wegener's granulomatosis. Yes, very good. Is it a squamous cell carcinoma? No. What am I seeing? This is your calcified body within the giant cell. This is called as what? Schaumann body. And what are you seeing here? Within the giant cell, a star-shaped body, asteroid body. Where do you see both of them? Sarcoid, correct, sarcoidosis. Both of them sarcoidosis. Okay, let me give you, this is a biopsy from a farmer who has presented with breathlessness, fibrotic patches in the lung, then spirometry suggestive of interstitial lung disease. Yes sir, tell me now, what are you seeing? Spirometry suggestive of interstitial lung disease. Is this also sarcoidosis? Because sarcoidosis also there is a giant cell scene and a granuloma scene. We can understand this is a giant cell here. But history farmer has been given, and yes, calcium level normal. Very good, very good. Giant cells and inflammatory cells. That is what I can identify. I can keep 2 DDs in this. TB is ruled out almost. Why? Fibrosis is there, and okay, not ruled out. In India, we can still consider TB also. I have to do TB PCR and all those things to prove it negative for TB. And sarcoidosis is a diagnosis of exclusion. History of farmer which can have exposure to the grain dust, and yeah, it can be a diagnosis. TB can be a diagnosis. TB cannot be a, we cannot say no to TB in India. Okay, so we have to rule out TB every time, because treatment for other condition will be steroid, and if you are giving steroid in TB, you worsen it. We always end up doing TB PCR first, negative, or AFB you should do. Okay, so with this history, I would think, okay, my DDs would be TB, yes, correct. Other than that, I can think of sarcoidosis and hypersensitivity pneumonitis. Giant cell and granuloma, keep one diagnosis of what? Hypersensitivity pneumonitis. Farmer's lung, yes. Answer, don't answer. Ask for options and question, always. Again, I say this. The best way to answer image-based question in pathology is not to look at the images. Images are not your keywords. Images are just given to distract. मतलब बोलते हैं ना, पिक्चर में ना हीरोइन को ठीक है देखो, लेकिन स्क्रिप्ट को देखना जरूरी है. Okay, so I know all of you are behind heroines, but for exam, go behind the script. Look at the question and look at the option. They are the hints. Okay, let us look. What is it? Non-smoker, female, weight loss, peripheral lung lesion. Yes, sir. What are you thinking? Image is fine. Image is fine. Yes. Very good. Gland formation. That is what is there. Gland formation. What is your diagnosis? Adenocarcinoma of lung. Adenocarcinoma. Yes. Yes, sir. Tell me now. What is the diagnosis? Okay. Marker. Marker. Napsin A. TTF1. Marker. Napsin A. TTF1. This is not azoparty. And genetics. EGFR most common. ALK and KRAS. I have written them in decreasing order only. Okay, this is another lung biopsy. Patient is have a smoker, weight loss, confusion, delirium. Okay, I have asked you diagnosis, marker and genetics. I want to ask one more question. What is the cause of confusion and delirium here? Cause of confusion and delirium. Cause of confusion and delirium. Okay, to investigate cause of confusion and delirium, which investigation should you be doing? Electrolytes or MRI of brain? Imaging of brain or serum electrolytes? What do you want to do? Look, question, same thing, I have just twisted it. Everybody has made a diagnosis, but let me see my question. How many of you are answering? Brain imaging or serum electrolytes? Very good, very good. See, simple. So, electrolytes. Why? What is your diagnosis? Look at this. These are all what? Small round blue cells which are forming what? Tumor. No gland, nothing. So, this is a small cell carcinoma. Very good. And confusion and delirium, not because of metastasis to the brain. It is due to what? SIADH. SIADH leads to excess of ADH, which will lead to dilutional hyponatremia. Sodium level should be measured here. Markers and genetics has been asked. What will be the markers here? It's a neuroendocrine tumor. So, markers will be chromogranin, synaptophysin. That will be the marker. Chromogranin, synaptophysin, TTF1. TTF1 is a marker for lung and thyroid tumors. Genetics, P53, RB and MYC. P53, RB, MYC. Very good, very good, very good. अच्छा, तो ये तो सब पता ही है आप लोगों को यार, मतलब you will end up excelling in pathology. You will end up excelling for sure in pathology. Okay, चलो for exam at least, huh? Yes, and I want that for exam first. Smoker, weight loss, hypercalcemia. बताओ क्या diagnosis है? What is the diagnosis? And this is the image, biopsy from the lung. Yes, biopsy from the lung. Keratin pearl. What is your diagnosis? Keratin pearl, squamous cell carcinoma. Markers of P40, P63. Markers P40, P63. Genetics P53, EGFR. Location centrally located. That's why it will be more likely to present as hoarseness of voice. Both squamous and small cell can be centrally located. The azopardy will be seen in small cell carcinoma. Because of nuclear crushing, the DNA of the dead cells will be deposited on the blood vessel. That is azopardy. Okay, history. Smoker, weight loss, industrial worker, worked in fireproofing. So he worked in fireproofing. What is used in fireproofing? And what is the diagnosis? What is the EM finding also? As markers and EM finding. Fireproofing, asbestos. Smoker with asbestos. Weight loss, again I am suspecting a malignancy. What are you seeing? Look at this. These are your what? Gland formation. Are you seeing gland formation? Yeah, looks like adenocarcinoma. Very close DD for adeno. But on the other side, you are seeing these are your spindle cells with pleomorphism. So it is a biphasic tumor. Glands are seen and spindle cells are seen. Biphasic tumor, diagnosis mesothelioma. Markers for mesothelioma, calretinin. That is a marker for mesothelioma. And EM will show long microvilli. Adenocarcinoma will show short microvilli. And meso will be showing long microvilli. Okay, next question. Dyspepsia and diagnosis, malignancy arising from it. One more question I'll add. What is the stain used here? Patient having dyspepsia. This is a upper GI biopsy. Upper GI biopsy. What is the special stain used here? And other questions. Okay, look at this black color. All these are comma-shaped organism, bacilli. What are those? H. pylori. What is the special stain? Special stain, Warthin starry. It is also called silver stain. Warthin starry stain. Correct? And what malignancies? Maltomas and gastric carcinoma. Gastric maltoma, 100% association. Most specific malignancy with H. pylori is maltoma. Maltoma. Warthin starry is a silver stain. Correct. Okay. Cross-examination of stomach. Patient had diarrhea, weight loss. What is the diagnosis? What is the pathogenesis? This is a cross-examination. What are you seeing? Look at this. These are your mucosal rugae or gastric folds. And the gastric folds are very huge here. Yes. So hyperplastic gastric folds. Almost looking like your sulci gyri of the brain, by the way, right? Yes. What is this? What is this? Menetrier's disease. Very good. Absolutely correct. What is the pathogenesis? Pathogenesis. Excessive TGF alpha. Excessive TGF alpha. Mutation of TGF alpha can be there. Next. Diarrhea, duodenal tumor on histology, increased gastric folds in the stomach. Question asked is diagnosis. What if it is familial? Associated with which familial condition? This one is associated with which familial condition? So multiple things I am asking you. Okay, first let us focus on image. What is their image? Focus on these cells here, around this cell, my hand. Look at this, the nucleus. Nucleus is appearing, the nucleus is appearing like black dots like this. Look at this. This is your nucleus. And in that you are seeing like this, background is white and you are seeing what? Multiple dots. This is called salt and pepper chromatin. Where do you get salt and pepper chromatin? Yes, very good. Salt and pepper chromatin, neuroendocrine tumors. And history of duodenal tumor, I can think of a carcinoid of the duodenum. Diarrhea is there and increased gastric fold. Can anybody tell me increased gastric fold? What will it be secreting? Increased gastric fold. What will it be secreting? Gastrin secreting neuroendocrine tumor. Gastrinoma will be my diagnosis. Correct? Gastrinoma. Otherwise, I can just call it what? Neuroendocrine tumor pathologically, but clinically it is gastrinoma because it is secreting gastrin most likely. Yes, Zollinger-Ellison syndrome. Familial condition, I asked you. Gastrinoma, which men syndrome? Can anybody? Yes, men 1 can be there. Correct? Very good. Somebody has answered this. Men 1. Yes. Okay. Next question. Let us look at this. This is a biopsy from duodenum. Okay. Diarrhea, duodenal biopsy. Diagnosis, management and malignancy arising from this. So look, what are you seeing here? These should be on the top of this. What should you be seeing? There should be what? Villi that will be seen. Normally, your villi should be like this, like this, like this. But I don't see any villi. So what are you finding in this then? There is a villus atrophy. Correct. Villus atrophy is seen. And also your crypts. Look at this. These are the crypts that are there. And these crypts are extending all the way up till here. Crypt hyperplasia. Yes, sir. What are you suspecting? Celiac. Only thing, is it diagnostic? No. I have to put the patient on gluten-free diet. That's the treatment. Put on gluten-free diet and villi should grow back to normal. Isn't it? Yeah. And which malignancy? Very good. T-cell lymphoma. Can anybody tell me which type of hypersensitivity is celiac? Celiac is which type of hypersensitivity? Type 4 hypersensitivity. Okay. No, diagnostic feature is a reversal of changes after gluten-free diet. That is the diagnostic feature of celiac disease. Not serology, not biopsy. Both of them will be suspicious. That's it. Okay. History. Steatorrhea, duodenal biopsy. Peripheral blood and duodenal biopsy have been given. Peripheral blood, acanthocytes. And on duodenal biopsy, what are you seeing? Look at these. Epithelial cells having lipid droplets. Yes, sir. What is it? A-beta lipoproteinemia. Correct? A-beta lipoproteinemia. Acanthocytes and lipid-laden vacuoles. Mutation. What is the etiology? Etiology of A-beta lipoproteinemia? MTP mutation. Microsomal triglyceride transport protein mutation. MTP mutation, it is an autosomal recessive condition. Right? Okay, another biopsy from the duodenum. Duodenal biopsy, joint pain has been given, steatorrhea is there. Patient is having joint pain, steatorrhea. Is it celiac? No. Look at the villi. Very tall. Villi are tall. It cannot be celiac. Now look at this. This is your villus. What is this part called as? What is this part beneath the villus? What is this called as? This is your lamina propria. This is the lamina propria of the villi, isn't it? And lamina propria is showing macrophages here. Macrophages in the lamina propria. Very good, very good. All of you are right, absolutely. So these are foamy macrophages in the lamina propria. If I do pass, they will be pass positive. They are nothing but organism. Which organism? Whipples. Diagnosis, Whipple. Organism, T. whippli. T. whippli. Tropherima whippli. What will be the treatment for this condition? Antibiotics, of course. Okay. Abdominal pain, bleeding PR. Total colectomy has been done, and this is the magnified image of one of the areas of total colectomy. Yes. So look what you are seeing. These are the hyperplastic mucosa bulging out. This is the ulcerated area. There is mucosa which is bulging out like this. This is your pseudopolyps that you are seeing. Where do you see pseudopolyps? Ulcerative colitis, correct. Okay. Keyword, question. Megaloblastic anemia in a patient, abdominal pain, ileal biopsy. Okay. Ileal biopsy, abdominal pain and megaloblastic anemia has happened. This is a biopsy. What are you seeing here? Look at this. This is a big granuloma that you are seeing. A submucosal granuloma in a ileum. What are you suspecting? One, of course, we still suspect TB. Another, my closest DD will be what? Crohn. Yes, TB and Crohn both will be there. Yes, I have to rule out TB always. Yeah. So, submucosal granuloma, more likely Crohn disease. Okay. Yes. And patient is having B12 deficiency. Why B12? Yes, of course I have to look even for, what do you call, transmural inflammation, all those things. Okay. Let us look at this. This year INICET question. They did not ask directly. 5-year child bleeding PR diagnosis. What are you seeing? Look at this 5-year child bleeding PR diagnosis. What are you seeing? These are the dilated glands that you, this is a polyp by the way, and there are dilated glands that you are seeing. Are you seeing these are all dilated glands? Yeah, dilatation of these glands is a hamartoma that is happening. So it is an hamartomatous polyp here. Yes, it is a hamartomatous polyp. In that it is a juvenile polyp, JP, juvenile polyp, or also called retention polyp. Juvenile is a hamartomatous polyp. Remember, Peutz-Jeghers and juvenile polyp, both of them are hamartomatous polyp. Right? This is a hamartomatous polyp. Dilated glands within the polyp and inflammation will be there. Ulceration and inflammation. Juvenile polyp. No, this is not pre-malignant. Rarely it can become not pre-malignant. That is what you should be knowing. Hamartoma means disorganized growth. Hamartomas are disorganized normal structures, but they are disorganized. Right? That is hamartoma. 11-year-old child, gum hyperpigmentation, bleeding PR. And what is the diagnosis? Yes, 11-year-old child, gum hyperpigmentation, bleeding PR. And this is a polyp from the intestine. This is also an hamartomatous polyp. What are you seeing in this hamartomatous? Very good, very good. Yes, you are seeing there is, look at this Christmas tree like branching. There is a muscle which is going and splitting like this, like a Christmas tree, called arborizing pattern. In between you are seeing dilated glands again. So this is your another type of hamartomatous called Peutz-Jeghers polyp. And this will be a Peutz-Jeghers syndrome. Hyperpigmentation is also seen commonly in Peutz-Jeghers syndrome. Called as arborizing pattern. What mutation? Yes, correct. SKT11 mutation. Arborizing pattern of smooth muscle dissecting the glands. History. 50-year bleeding PR. What is the diagnosis? Bleeding per rectum, 50-year. What is the diagnosis? Don't make it hamartomatous polyp because they occur in children. This is a pedunculated polyp, and within the polyp you are seeing branched out glands. There is branching of glands that you are seeing, and some dilatation of the glands also. This is your adenomatous polyp. Correct. This is your adenomatous. Which adenoma? Adenomatous polyp. Correct. Which adenoma? This is a tubular adenoma. Tubular adenoma. Easy to remember. Keep it in mind like this. Tubular adenoma is like a cauliflower. There is a stalk, and there will be what? Multiple branches that are seen. Okay. Cauliflower like. Tubular adenoma. Now, same history. 50-year bleeding PR. What is the diagnosis? So now look at this. This is a non-pedunculated. It is a sessile polyp. Everything is arising. There is no stalk here. And these cells are like what? Tall villi like. Tall grass like appearing from the base only. This is not having a stalk like a cauliflower here. This will be like what? Grass that is growing on the intestine. This is your villus adenoma. This is your villus adenoma. Tall finger-like projections, no stalk, villus adenoma. Villus. Same history again. Tell me now, what are you seeing in this? Same history, what are you seeing in this? Look at this part. Can you see what are you seeing here? Of course, you are seeing tall grass-like projections that are coming, and there is no stalk here. Yes, this is your villus adenoma part. And on the other side, you are seeing, look at this, there is a branching gland. There is a tri-branching. 3 branches are there. 1, 2, and 3 like a Mercedes-Benz. This is more complex. 1 branch, 2 branch, 3 branch, 4 and 5 branches. So this is also one like this and another like this. 4 branches, 3 branches. So branching glands are seen on one side and villi are seen on one side. This is your tubular part. This is your villus part. So this is your tubulovillus adenoma. Tubulovillus adenoma. Clear all of you? Let us see. Alcoholic patient, identify the structures which are pointed and what is the content of that structure. A patient with alcoholism, chronic alcoholic. Yes, sir. What are you seeing? And this is a liver biopsy. This is your adipocyte. Of course, these are your fat that you are seeing. Fatty liver is there. In addition, look at this pink structures that are there. These are Mallory's hyaline. Mallory hyaline or Mallory bodies or Mallory Denk bodies. Any word you can use. Mallory body containing what? Cytokeratin intermediate filaments. They are intermediate filaments of keratin, cytokeratin. Very good, very good, very good. Yeah, all of you know everything. Okay. Another liver biopsy. This is a pass stain. Patient is having respiratory difficulty and is also having hepatitis. Diagnosis. What is the diagnosis? This is a liver biopsy. And what lung lesion will be seen? Yes, sir. Mallory's hyaline, cytokeratin intermediate filaments. Respiratory difficulty, no, these are not Councilman bodies. Councilman bodies should have fragmented nuclei also in that. Councilman bodies are apoptotic bodies, right? बताओ क्या है ये? Respiratory difficulty, hepatitis, what are you seeing? Pass positive, what is this? Very good. These are pass positive globules in the hepatocytes seen in alpha-1 antitrypsin deficiency. Patient is having a barrel chest like that. History I can give you. Nothing but emphysema. Pan-acinar emphysema is associated. Pan-acinar emphysema. Alpha-1 antitrypsin deficiency. Last slide there was, okay, I'll show you. This is your pink hyaline material along with fat you are seeing. Fatty liver is also there. Alcoholism, that is why. Okay. This was the last slide was Mallory bodies. And this is more, and of course, I told you again, don't look at the script. Look at the script. This is not alcoholic history, right? So that's why I'll not make Mallory bodies here. Look for keywords. For Councilman bodies, I told you, Councilman bodies will look somewhat like this. There will be nuclear fragmented. Fragmented nucleus will also be there. And Councilman bodies will be very, very small, not so big. It will be small, very small. Ulcerative colitis patient, jaundice, and this is a liver biopsy, and you are seeing this is a bile duct shown to us. BD, I am writing bile duct. And what are you seeing here? Look at this. This is your onion skin fibrosis of the bile duct. Anybody? What is onion skin fibrosis of the bile duct? Where do you see? Very good, very good, very good, very good. PSC, very good. What is it? Primary sclerosing cholangitis. Primary sclerosing cholangitis. Yes, gland is, this is a duct actually. Yeah, Councilman bodies will be seen in acute viral hepatitis. Okay, let me see. This is electron microscopy. Hematuria 2 weeks after respiratory infection. Diagnosis. And this is a EM finding. What are you seeing? EM is showing these are your what? Big hump-like deposits. क्या बोलते हैं इसको? Sub-epithelial humps. Sub-epithelial humps. What is your diagnosis? PSGN. Post-streptococcal glomerulonephritis. PSGN. Yes. Next. Let's see this question. Hematuria, azotemia, anuria. And what are your DDs? I am asking you DDs. Patient is having hematuria, azotemia, anuria. Anuria means renal failure has happened. And this is a kidney biopsy. What are your DDs? What are you seeing here? Look at this. This is a structure which is like a half moon. क्या बोलते हैं इसको? Crescent. Very good. Clinical DD, RPGN, or I can call it crescentic glomerulonephritis. Correct? These are your crescents that you are seeing. Diagnosis, crescentic glomerulonephritis. Tell me what are the DDs for RPGN? We divide RPGN into three types of RPGN, type 1, type 2 and a type 3 RPGN. Type 1 RPGN, anti-GBM mediated. Example, good pasture syndrome. Type 1 RPGN is a type 2 hypersensitivity reaction. Type 2 RPGN is immune complex mediated, which is a type 3 hypersensitivity reaction. Causes commonly lupus, HSP, rarely IgA nephropathy can cause. And type 3 post-immune, which are not immune, that is not a hypersensitivity reaction at all, Wegener, Empan and Church-Strauss. How do I differentiate on IF? Differentiation will be done on immunofluorescence, linear pattern in good pasture, granular pattern in immune complex mediated, post-immune, no deposits at all. Post-immune, no deposits at all. So this can be any one of them. I cannot comment whether it is a good pasture or anything. Crescents will be seen in all of them, right? So you give me other keywords, I will end up answering it. Okay. Yes, sir. Same patient, crescent on biopsy, and this is the IF. Hematuria, hemoptysis, crescents on biopsy, this is the immunofluorescence. What are you seeing? On IF, linear pattern, how does it appear? Look at this pattern that you are seeing here. Just a minute. Yes, sir. What pattern you are seeing here? Yeah, tell me. So this is your line-like pattern, like this continuous line. This is called as a linear pattern. So what's your diagnosis? If this is a linear pattern, what's your diagnosis then? Yeah, linear pattern, good pasture syndrome, right? This is a linear pattern, good pasture syndrome. Okay, look at this crescents again, and this is another pattern. This is what, instead of continuous line, you are having dotted line like this, isn't it? This is called granular pattern. This is your granular pattern. Yes, where do you see granular pattern? Granular pattern will be seen in type 2. RPGN, MPGN should not be confused. RPGN is a clinical terminology where any acute nephritic can manifest with renal failure, that is called RPGN. Crescents will be seen. In MPGN, you will be seeing tram track appearance, and it will present with nephritic predominantly, can even have nephrotic range also. Okay, keyword arthralgia, hematuria, anuria after pharyngitis. Yes, is it IgA nephropathy or is it HSP? Diagnosis HSP here. Why HSP? Crescentic glomerular. IgA nephropathy rarely causes crescentic glomerulonephritis, and also arthralgia history has been given to us. HSP. Yes. Okay, this is a kidney biopsy. This is a special stain. What is the special stain here? Silver stain is done. Okay. This is your, just a minute. Silver stain. Can you identify what is it showing you? Look at this. These are the glomeruli, and there are double basement membrane and two parallel basement membrane, जैसे कि tram की track है, right? So this is called tram track appearance. Double basement membrane you are seeing, isn't it? Tram track appearance. What is tram track appearance? Where do you see such a tram track appearance? Okay, this is a silver stain. Tram track appearance. MPGN, correct? MPGN, both MPGN type 1 and type 2. Difference between MPGN type 1 type 2. Type 1 MPGN will have immunoglobulin, IgG deposit, C1, C3, C4 deposit. Type 2 only will have C3 deposits. Okay, next image. Patient is having, okay, history. Hematuria, light microscopy shows tram track appearance. EM is as below. This is the basement membrane. Look at this. These are dense deposits in the basement membrane. So where do you see such dense deposits in the basement membrane? Dense deposit disease, also called as type 2 MPGN, or also called C3NEF disease. C3NEF is C3 nephritic factor. Okay sir, chalo ye batao. Yes, in MPGN type 1 subendothelial deposits will be seen. Tell me now, history. Let me give you history. Nephrotic syndrome, elderly male. And what is your diagnosis? Nephrotic syndrome, elderly male. And what are you seeing here? Yes, spike basement membrane is showing spikes. Spikes in the basement membrane. Spikes in the basement membrane. Membranous, correct? So basement membrane, look again, this is a silver stain, and this the dark one, it is showing what? Spike like appearance, right? So this is how the spike is appearing. History. Nephrotic 4-year-old child, no change on light microscopy. Light microscopy inconclusive. And what are you seeing here? This is the basement membrane. This is the epithelial side. There are no food processes. Yes, effacement of food processes. Effacement of food processes. What is it? Effacement of food processes. Minimal change, especially with no change on light microscopy. 4-year. No, not Alport. What is this? Patient is HbA1c of 12. Kidney biopsy. These are nodules. There is a sclerosis in the glomeruli and forming nodules. Nodular glomerular sclerosis called Kimmelstel-Wilson lesion. Kimmelstel-Wilson lesion. Okay, child with deafness, renal failure, and what is your diagnosis? Child with deafness, renal failure, what is your diagnosis? Okay, look at this. What are you seeing? See, look at this, the basement membrane. The basement membrane is thick here, thin here, again thick here. Okay, again thin here, again thick and thin. Look at this, basement membrane is appearing what? Alternate thick and thin. That is called basket weave appearance. Very good. This is Alport. And also, carefully look at this line. This is your lamina densa, dark layer, lamina densa. And this is also lamina densa. So you are having two lamina densa, splitting of lamina densa. Both of them are seen in Alport, basket weave and splitting of lamina densa. Alternate thinning, this is called basket weave. Okay, keywords: asymptomatic renal tumor, diagnosis and association. Already told, angiomyolipoma. This is angiomyolipoma, written here already. What are you seeing? There is blood vessel, angio blood vessel, lipo is a fat, and muscle around the blood vessel, there will be proliferation of muscle, angiomyolipoma. Association, tuberous sclerosis. Yes, this was also discussed in radiology as well, right? So we are having correlation now. So yes, look at this. Let me give you a history. Hematuria, renal mass. What is the diagnosis? What is the cell of origin? What is the inherited cancer syndrome? Of course, I can see clear cells I am seeing here. Diagnosis, clear cell RCC. Clear cell RCC. Diagnosis. What is the cell of origin? Proximal tubule is the cell of origin. And inherited cancer, von Hippel-Lindau syndrome, VHL, associated with polycythemia. Next, hematuria with renal mass, diagnosis and cell of origin. Look what you are seeing, perinuclear halo. This is not clear cell. And the cell membrane is very what? Thick and well defined cell membrane like this, called plant cell appearance. Thick cell membrane, plant cell appearance. Diagnosis, yes, chromophobe RCC. Cell of origin, intercalated cells of collecting duct. Chalo guys. Next one. 5-year-old hematuria with renal mass. What is the diagnosis and what are the inherited conditions associated with this? Look what you are seeing here, tubule. There is a tubule formation. These are what? Small round blue cells without forming anything. These are blastema. This is the epithelium, tubule formation, and there are few spindle cells also there. This is a triphasic Wilms tumor. Blastema, tubule formation, spindle cell. Triphasic Wilms or nephroblastoma. Inherited conditions I have given you. Vagar syndrome, Dennis-Drash syndrome, Beckwith-Weidman. The first two, Vagar and Dennis-Drash, are associated with WT1 mutation, loss of function of WT1, because WT1 is a tumor suppressor gene. Beckwith-Weidman is gain of function of WT2 because WT2 is a proto-oncogene. WT2 is a proto-oncogene. Yes, इंटरवल अभी होगी, डोंट वरी, अभी खत्म ही हो गया ना, जनरल के लिए बीच जनरल के लिए आपको इंटरवल मिलेगी, डोंट वरी. ओके, यस सर. This is a testicular, I need not tell you, this is a testicular tumor. Gross microscopy. Gross homogeneous gray white tumor, no areas of hemorrhage necrosis. Seminoma. Same thing in ovary, dysgerminoma. Microscopy, what you are seeing? Clear cells with fibrous septae which are containing lymphocytes. So clear cytoplasm and lymphocytic infiltrate in the fibrous septae. Seminoma, in ovary it will be dysgerminoma. Okay, markers I have given you, podoplanin, NOC 34, CD117. This is another testicular tumor. What are you seeing? Look at this tumor now. Is there homogeneous gray white or hemorrhage and necrosis? This white areas are necrotic areas and this red is hemorrhage, by the way. Hemorrhage and necrosis means it is a more rapidly proliferative tumor. This is a non-seminomatous tumor. Suspecting a embryonal carcinoma. What are you seeing here? On microscopy, gland-like structures and pleomorphic cells and mitosis. This will be your embryonal carcinoma. Yes. This is a testicular biopsy, or okay, let me see what is the given. 10-year testicular biopsy, AFP elevated. What is the structure seen? Schiller dual body. This is your Schiller dual body. How does it look? In the center, blood vessel surrounded by tumor cell, again surrounded by an empty space. Schiller dual body, or also called, what is this tumor? Endodermal sinus tumor or a yolk sac tumor. This appears like a remnant of yolk sac of rabbit, and that is why it was called as yolk sac tumor. Schiller dual body. Yeah, this is not an ovarian tumor. These are germ cell tumor, occurs in places where there are germ cells, in boys, in testes, in girls, in ovaries. So same tumor can occur in both. Oh, this one, testicular tumor, precocious puberty. In a boy, precocious puberty means it is an androgen secreting, or yes, it is an androgen secreting tumor. Precocious puberty. Look, what are you seeing here? These are, okay, image I am not expecting, but I am expecting what is the finding here. These are very good crystals of ring K. What is the diagnosis? Where do you see such crystals of ring K? Even here also you are seeing this is also crystal of ring K. This is also crystal of ring K. Where do you see them? Leydig cell tumor, correct? Okay, Leydig cell tumor, crystals of ring K. Yes, sir. Breast biopsy, 2 tumors. This is the one which is showing duct-like structures. What is this? Ductal carcinoma. Ductal carcinoma, duct formation, ductal carcinoma. And look at this, the tumor cells are arranged in a single file, one behind each other. Single file pattern, lobular carcinoma. Lobular carcinoma. Schiller dual body, central blood vessel surrounded by tumor cell, surrounded by empty space. This is called single file or Indian file pattern, lobular carcinoma. Okay. Testicular biopsy, Desmin positive. Look what you are seeing, spindle cells with hyperchromatic nuclei, and I am seeing cross striations here. Cross striations कहाँ पे दिखेंगे? यहाँ पे तो अच्छा दिख रहा है, right? This is a cross striation. Can you identify cross striations here? Yes. Where do you see cross striations like this? Striations are seen in skeletal muscle. This is a tumor differentiating towards skeletal muscle. What is your diagnosis? Rhabdo. Very good. Rhabdomyosarcoma. Rhabdomyosarcoma can occur in testis or periorbital in the face in children. Okay. Okay. Tinnitus, CP angle tumor, diagnosis and inherited cancer syndrome. What are you seeing? Look at this. There is one row of nucleus and there is another row of nucleus. In between, nucleus is not there. Nuclei free zone. Such nuclei free zone are called Verroque bodies. And this is your palisading of the nucleus. Nuclei are fencing, two nuclei. Look at this, nucleus here, like fencing, and they are guarding your what? Nuclei free zones. Such a nuclei free zone is called Verroque body. Where do you see this? Schwannoma. Very good. Schwannoma. Nuclear palisading, central nuclear free area, schwannoma, markers, etc. I have discussed. NF2, correct, associated with NF2. And this is hypercellular area, that is called antennae A area. The hypocellular will be called antennae B. Okay, look at this. What is this now? History. 10-year boy, bone tumor, Codman triangle on X-ray. What are you seeing here? This all pink material, this is your osteoid with a lot of pleomorphic cell. If osteoid is formed, this is nothing but what? Osteosarcoma. Osteoid formation. Pleomorphic cell, osteosarcoma. Another history let me give. 10-year-old child, bone tumor, Codman triangle on X-ray. This is the biopsy. So remember, there can be small cell osteosarcoma also happening, but this is showing you, look at this, the tumor cells are arranged in a fashion where they are forming like what? A rosette. This is your rosette. Circular cells arranged in a circular fashion, that is rosette, and there are some cytoplasmic processes in the center of this. This is Omer-Wright rosette. Omer-Wright rosette seen in Ewing spinet, correct? Markers CD99, genetics 1122 translocation. Next. Yes, bone tumor, osteolytic bone tumor, diagnosis, cell of origin. Definitely we can see these are all what? Giant cell, large cells, giant cells. And what is the diagnosis? Giant cell tumor of bone, osteoclastoma, giant cell tumor of bone, and there are mononuclear cells also present. Diagnosis, giant cell tumor of bone. What is the cell of origin? Cell of origin is not a osteoclast. Remember, cell of origin for giant cell tumor is a osteoblastic precursor. Osteoblastic precursor, very less seen. We cannot see those tumor cells in the tumor. Giant cell tumor, expect this question. What is the cell of origin of giant cell tumor? Not osteoclast, it is osteoblast. Okay, history. Orbital tumor, child with orbital tumor, name the structures and what is the cause. Look again, I told you, anything like this, like a round thing, these are what? Rosette. Now in Omer-Wright, I showed you there was cytoplasmic process going into the center of the lumen. Here the lumen is empty. This is Flexner-Wintestiner rosette. Look at this. Even here also there is a lumen being empty here. Even here also I can see lumen being empty here, lumen empty. Flexner-Wintestiner rosettes. Where do you see? Orbital tumor, definitely I will make a diagnosis of what? Retinoblastoma. Other causes? Pineoblastoma, medulloepithelioma. Flexner-Wintestiner rosettes. Okay. Let me see. 8-year-old retroorbital tumor. What is the diagnosis? What is the marker? Arrow mark is pointed. This is your Rosenthal fiber. And look, very thin processes are coming out of the cell. Hair-like processes are coming. This is pilocyte. So hair-like projection, this is a diagnosis, pilocytic astrocytoma, also called optic nerve glioma, marker GFAP. And what you are seeing? Rosenthal fibers. Okay, brain tumor, 40-year-old. What is the diagnosis? Look, you are seeing a central area of necrosis surrounded by nuclei here. So this is called, actually what? There is a necrosis, this is viable, this is a necrotic area. Central area is necrotic. It appears as if the tumor cells are lining or fencing around the necrotic area. It is called palisading, pseudo-palisading. Central area of necrosis, peripherally arranged nuclei, pseudo-palisading. Pseudo-palisading. Yes, of course, crosses the midline on what do you call radiology? Glioblastoma. Very good. Okay, brain tumor, genetics, what you are seeing. Okay, in the center, this is a calcified body. You are seeing a calcification here. Then these are capillaries, filled with RBCs also, chicken wire capillaries, and you are also seeing some pericytoplasmic halo, clear halo, which is called fried egg appearance. Fried egg appearance, chicken wire capillaries. Where do you see fried egg and chicken wire capillaries? Sorry. Oligodendroglioma. Oligodendroglioma. Genetics 1p19q co-deletion. Brain tumor. What is the diagnosis? I am not given any history. Yes, let us look what you are seeing here. Look, there is a central blood vessel here, and surrounding the blood vessel there are tumor cells. Even here also you are seeing a central blood vessel. RBCs are there. Surrounding that there are tumor cells like this. So it looks like a rosette. This is called pseudo rosette. Perivascular pseudo rosettes. Seen where? Ependymoma. Perivascular pseudo rosette. Ependymoma. Yes, sir. Tell me what is this now. Let me give history. 40-year female, tumor in the fox. This looks like keratin pearl. Don't make a diagnosis of squamous cell carcinoma. Fox means squamous cell carcinoma nahi ho sakta hai. In the fox, this is your whirling pattern, and some of them are psammoma bodies already. Okay. So this is your psammoma bodies, whirling pattern with psammoma bodies, meningioma. Meningioma. Yes. आंखें किसके दिख रहे हैं यहाँ पे? किसको आंखें दिखाना है हमको? Let me look what is a 25-year thyroid tumor. Whose eyes? Whose eyes? Orphan Annie. What is Orphan Annie eye? Look at the nuclei. Look very clear. Very, very clear nuclei. Isn't it? Orphan Annie eye nuclei. It is a cartoon character. मैंने नहीं देखा है तो देखना तो देख लो. Orphan Annie पता नहीं कब का है cartoon. But looks like this, you know, Orphan Annie eye nuclei. अच्छा, Orphan Annie. Any other eye? Owl eye. Owl eye कहाँ मिलता है? CMV and also in Reed-Sternberg cell, right? Yeah, papillary thyroid carcinoma. Last slide, I guess. Let me give history. 5-year-old thyroid tumor. Patient is having hypertension. Child is having hypertension. Family history is positive. Parent is also having thyroid tumor. What is your diagnosis and what are the other tumors associated with this condition and what is the genetics? Okay, I can see these are the tumor cell and I am seeing in between pink material that is there. What is this pink material that you are seeing, sir? Pink material. What is the pink material? Pink material. Oh, very good. Amyloid. Konsa? What is the amyloid deposited here? Correct. This is your amyloid. What amyloid it is? Tell me. Tumor amyloid is deposited. This is your medullary thyroid carcinoma. Can anybody tell me why this patient is having hypertension? Why is this child having hypertension? Medullary carcinoma, correct, of thyroid, amyloid deposition. Acalcitonin is there. Okay. Can anybody tell me why hypertension? Association, pheochromocytoma. That is why hypertension. Familial condition, MEN2 syndromes. RET mutation will be seen. Right? Yeah. Amyloid will be acalcitonin. Amyloid calcitonin. Amyloid calcitonin. Right? Yes. So, yeah, there we end up finishing our topic. Now, one advice from me. Just imagine when you go into exam, just think that I am the examiner and you answered all questions perfectly in this class. You just have to carry this confidence forward. Do not ever doubt yourself. Now, second advice from me. Only one advice I'll give you. Another advice, sorry, apart from this. Solve GTs. You cannot miss GT. Every one of you. You want to get a good rank, solve one GT every week. If you are not doing, this is the minimum GTs I am telling you. If you are not doing this, you will not end up getting a good seat. I know many of your scores will be low. Even if your scores are low, I keep telling this, you are like electrons. Keep jumping from one orbit to another orbit. So when do I jump from one to the higher orbit? We never know. You might be currently at 100 orbit, that is your score is at 100, but once you jump, you end up suddenly jumping from 100 to 150. And this might happen in Jan, Feb, March. Hope it is in Jan, Feb or December only, not in March, because after exam jump karke kya fayda? Koi fayda nahi ho raha hai hamara. Of course, it can happen in INICT also, But if you do not give yourself a chance, you will never know. You will stay at 100 wala orbit or 150 wala orbit. If you give yourself a chance, you will at least know that I might jump to what? 150 wala orbit. So that is why I want, no matter what, the most important thing, persistence with your grand test. Please be persisting with your grand test, and I'm sure all of you will end up having a very good score in exam. Okay? Yes, I hope I could summarize the whole of pathology, which is a very vast subject for me to finish off in so quick time, but I have tried to cover most of the topics in a very limited amount of time. Make sure revise pathology DVT at least 4 times from now. You will end up answering most of the questions in exam. Okay guys, bye all of you. Good night everyone from my side. Sorry, you still have another session. Very sorry for that. Yes, so I'll take a leave and we'll have the next faculty coming. Thank you all for your appreciation. Yeah, somebody is typing very big this one. Okay. Thank you all for your appreciation, and I end my session here. Right? Best wishes all of you.